Tasikmalaya is going to be started.
Ladies and gentlemen, welcome to International Seminar on Midwifery Student Association 2023, From Crisis to Resilience, Empowering Women and Ending Violence in Disaster at Poltekkes Kemenkes Tasikmalaya. Assalamualaikum warahmatullahi wabarakatuh.
Good morning and greetings for all of us. By say Alhamdulillah, let's give praise to Allah Subhanahu wa Ta'ala. With His bless, we can be present together in this place. Salawat and salam may always be given to our Prophet Muhammad Sallallahu Alaihi Wasallam and his family, his friends, and to all of us as his followers.
The Excellency, Mrs. Hajah Ani Radiati, Bachelor of Education, Master of Health, as the Director of Poltekkes Kemenkes Tasikmalaya. The Honorable, all speakers, Mrs. Nida Rohmawati, Master of Public Health, the Ministry of Health Indonesia. Dr. Hazel Kiddle, Doctor of Philosophy, Register of Midwifery, Lecturer at the School of Nursing and Midwifery, Western Sydney University. Mrs. Wiwin Mintarsi, Bachelor of Applied Science, Master of Health, Vice Director of Student Affairs Division at Poltekkes Kemenkes Tasikmalaya. Mrs. Rose Nanju, Master of Nurse, Lecturer at I System College, Malaysia. Dr. Elit Febriati, Master of Midwifery, Doctor of Philosophy, Lecturer of Midwifery at Poltekkes Kemenkes Tasikmalaya.
The Honorable Deputy Director of Poltekkes Kemenkes Tasikmalaya, Mrs. Wiwin Mintarsi, Bachelor of Applied Science, Master of Health.
The Honorable Head of the Midwifery Department, Mrs. Nunung Mulyani, Master of Health.
The Honorable Secretary of Department of Midwifery, Mrs. Dede Gantini, Bachelor of Applied Science, Master of Midwifery.
The Honorable Head of the Associate of Midwifery Study Program, Mrs. Hajah Yulia Herliani, Bachelor of Applied Science, Master of Midwifery.
The Honorable Head of the Associate of Midwifery Study Program, Mrs. Hajah Diah Widyastuti, Bachelor of Applied Science, Master of Midwifery.
The Honorable Head of the Bachelor of Applied Science in Midwifery Study Program, Mrs. Dr. Hajah Meti Widya Lestari, Bachelor of Applied Science, Master of Midwifery.
The Honorable all Lecturer of Midwifery Programs at Poltekkes Kemenkes Tasikmalaya.
Heads of study program at all universities throughout Indonesia who are willing to attend this morning, or the representative.
The Honorable Head of Tasikmalaya Ministry of Health, or the representative.
Honorable, all the invited guests who are willing to attend this morning, and all of the participants. Welcome to all of participants in this event's International Seminar on Midwifery Student Association, From Crisis to Resilience, Empowering Women and Ending Violence in Disaster, on Saturday, 16th of December, 2023. Ladies and gentlemen, let's open this event by properly say Basmalah. Bismillahirrahmanirrahim.
Singing the national anthem of Indonesia Raya. Ladies and gentlemen, please all rise. Ladies and gentlemen, please sit down.
Chief Executive Report. To Asia Konitatin Solihati, the stage is yours.
The Excellency, Mrs. Haji Adi Radiati, Bachelor of Education, Master of Health is the Director of Poltekkes Kemenkes Tasikmalaya. The Honorable all speakers, Mrs. Nida Rohmawati, Master of Public Health, the Ministry of Health Indonesia. Dr. Hazel Kidal, Doctor of Philosophy, Registered Midwife, Lecturer at the School of Nursing and Midwifery, Western Sydney University. Mrs. Win Mintarsih, Master of Health, Vice Director at Poltekkes Kemenkes Tasikmalaya. Mrs. Rose Nanju, Master of Nurse, Lecturer at I System College, Malaysia. Dr. Elit Febriati, Master Health, Doctor of Philosophy, Lecturer of Midwifery at Poltekkes Kemenkes Tasikmalaya. The Honorable Deputy Director of Poltekkes Kemenkes Tasikmalaya, Mrs. Win Mintarsih Purnamasari, Bachelor of Applied Science, Master of Health. The Honorable Head of the Midwifery Department, Mrs. Nunung Mulyani, Master of Health. The Honorable Secretary of the Department of Midwifery, Mrs. Dede Gantini, Bachelor of Applied Science, Master of Midwifery. The Honorable Head of the Associate of Midwifery Study Program, Mrs. Hajah Yulia Herliani, Bachelor of Applied Science, Master of Midwife. The Honorable Head of the Bachelor of Applied Science Midwifery Study Program, Mrs. Dr. Hajah Meti Widya Lestari, Bachelor of Applied Science, Master of Midwifery. The Honorable Lecturer of Poltekkes Kemenkes Tasikmalaya. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. First, I'd like to thank Allah Subhanahu wa Ta'ala for giving us His blessing so that we could hold this event together. Because of His mercy, we are attending this event in good condition. I'd also like to convey my gratitude towards all the lecturers in Poltekkes Kemenkes Tasikmalaya who help us in many ways, and also to all committee who struggle to make this event possible so that it can be carried out successfully. And thank you to all the participants from around the world who set your valuable time for coming to this event. On this occasion, I will briefly discuss our events and organization. Our organization, Tasikmalaya Midwifery Student Association, has held international seminars. And this year, we finally held another international seminar. And we are proud to present our international seminar from crisis to resilience, empowering women and ending violence in disaster. On behalf of the committee, hope this event can go well and smoothly. Without your support, we cannot do so. We are humbly asking for your support so that this event can run as well as possible. Thank you for joining this event. Hope you have the great experience from this seminar. Thank you for your attention. That's all from me. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to our Chief Executive for the report at this event. And for the next agenda, opening speech from the Vice Director of Academic Division of Poltekkes Kemenkes Tasikmalaya. Please welcome Mr. Sumarto, Master of Agriculture.
Okay, thank you. Can you hear my voice? Hello?
Yes, sir.
Okay. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. The Honorable Director of Poltekkes Kemenkes Tasikmalaya, the Honorable our keynote speaker, Dr. Nida Rahmawati, MPH, Director of Health for the Productive Age and the Elderly of the Ministry of Health, Republic of Indonesia. The Honorable Dr. Hazel Kiddo, PhD, RM, from the School of Nursing and Midwifery, Western Sydney University, and Ismsa. The Honorable Ros Nemji, nurse from Department Nursing at I System Kuching College, Malaysia. The Honorable Ibu Wiwin Mintarsi Purnamasari, SSIT MKes, and Ibu Elit Febriati, MKeb, PhD, from Poltekkes Kemenkes Tasikmalaya, and all our other guys. We are grateful to the Committee of International Seminar Student Association, HIMA, Midwifery Department, Poltekkes Kemenkes Tasikmalaya, to have arranged such as a beautiful program. Ladies and gentlemen, allow me in this opportunity to welcome all this International Seminar Student Association, Midwifery Department, Poltekkes Kemenkes Tasikmalaya participants by first saying our grateful and praise to the Almighty for all His blessing, grace, and mercies that have made us possible to gather here in this place in excellent condition and health. Dear keynote speaker, distinguished guests, and participants of International Seminar Student Association, Midwifery Department, Poltekkes Tasikmalaya, the topic on From Crisis to Resilience, Empowering Women and Ending Violence in Disaster. The topic is very relevant with Center of Excellence, COE, Poltekkes Kemenkes Tasikmalaya. The name is Health and Disaster Emergency, HD Center. Welcome to the international seminar. Welcome to the Health Polytechnic of Tasikmalaya, Poltekkes Kemenkes Tasikmalaya. The world is facing many challenges, especially in health emergency and disaster. We must address the sustainability agenda to deliver improvement, ability to resilience in the health crisis, especially on empowering women and midwifery role. Together with the public and private sector, non-governmental and intergovernmental organizations, scientists are responsible to build a better life for society and resilience in health crisis. We should be clearly aware of the importance of interdisciplinary cooperation. We need to promote cooperation within the profession and with midwifery, nurse, public health, other health workforce, and the public in the creation and application of knowledge of enhancing community health status, especially health emergency and disaster, and sustainable well-being. Hopefully, we all can significantly give more contribution to the nation advancement in the not too distant future. To all our distinguished guests and participants, thank you for your being here. Welcome and enjoy the international seminar. We open the international seminar, HIMA, Student or Association, Midwifery Department 2023. We pray together and say, Basmalah, Bismillahirrahmanirrahim. Finally, we would like to give you a pantun. Hari Selasa, ujian fisika. Harus belajar biar lulus. Kita bangga dengan hima kebidanan Polkes Tama. Semoga Polkes Tama maju terus. Seminar internasional ini sangat mewah. Semoga para peserta dapat ilmu dengan utuh. Billahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Thank you and good morning, everyone.
Thank you to Mr. Sumarto, Master of Agriculture, for the opening speech.
Ladies and gentlemen, thus are the opening of the International Seminar on Midwifery Student Association at Poltekkes Kemenkes Tasikmalaya. Now, we come to main agenda of the International Seminar on Midwifery Student Association at Poltekkes Kemenkes Tasikmalaya with the theme From Crisis to Resilient, Empowering Women and Ending Violence in Disaster, which is the presentation of material from our 5 speakers. This agenda will be led by our moderators, Ila Mardotila, Jane Rahmawati, and Delia Maulida.
All right, everyone. For the first session, will be led by Ila Mardotila. So, Ila, the stage is yours.
All right, Hilda and Desi. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to this Zoom meeting of International Seminar on Midwifery Student Association 2023 Poltekkes Tasikmalaya. Present by team From Crisis to Resilient, Empowering Women and Ending Violence in Disaster. I'm Ila Mardotila. It's my honor to have the opportunity to be a moderator for this seminar. First of all, let us say thanks and pray to Allah Subhanahu wa Ta'ala for giving us the grace of health and safety so that we can gather in this seminar. Okay, everyone, I will introduce the first speaker for today. She is a Director of Health for the Productive Age and Elderly of the Ministry of Health Indonesia. But before we start discussing, let me read the curriculum vitae of Dr. Nida. To the IT, could you help me share screen the curriculum vitae? Okay, Dr. Nida Rahmawati, Master of Public Health. She is a Director of Health for Productive Age and Elderly. She has graduated from Faculty of Medicine Andalas University Padang in 1997 and Master of Public Health Science Chulalongkorn University in 2011. The work experience, she is a Director of Health for Productive Age and the Elderly, August 25 until present. Acting Director of Public Health Governance, September 25 until October 2023. Wow, there's so many great experience from Dr. Nida. Okay, I have done for you the curriculum vitae of Dr. Nida, sorry, and I think Dr. Nida have already joined with us right now. Excuse me, doctor, are you there?
Ya, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, doctor. Hello, Dr. Nida, how are you?
I'm good, thanks.
Okay, doctor, before we start discussing, let me tell the audiences how the presentation will go. For the first, Dr. Nida will present the material. After that, there will be a question and answer session followed by a conclusion. Okay, Dr. Nida, have you ready for giving the material?
Yes.
Okay, everyone, now let's right away listen to the material that will be presented by Dr. Nida. Dr. Nida, the stage is yours.
Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to express my gratitude to Midwifery faculty of Tasikmalaya. This is my honor to be here to present about minimum initial service package on reproductive health in health crisis situation. Allow me to share the screen. Can you see my slide presentation? We already know that Indonesia is prone to disaster. Indonesia archipelago consists of more than 17,000 islands with more than 278 now, 278 billion people, according to the census 2020. And we are located on the Pacific Ring of Fire with a constant risk of volcanic eruption, more than 150 volcanic mountain in Indonesia. And also we often to experience of earthquakes, floods, and also we have a big tsunami in 2004 in Aceh. During the past 20 years, Indonesia has made a global headlines due to devastating natural disasters that resulted in the deaths of hundreds of thousands of human and animal lives, plus having a destruction effect on the land area. This situation usually causes displacement in large numbers and over a long period of time. So we have many refugees during the disaster. And Ministry of Health established the Minister of Health Regulation number 75 in 2019 about the National Health Cluster to take care and do the action for the many disaster, the natural disaster and non-natural disaster. We already know COVID pandemic is a non-natural disaster, and we already have the health cluster. First, the health service subcluster, and also there is a disease control and environmental health subcluster, reproductive health cluster, mental health subcluster, nutrition, and also disaster victim identification or DVI. And we now talk about the reproductive health cluster. During my presentation, if someone want to ask or give a suggestion or opinion, please write down in the chat book, and after I finish the presentation, we can directly to have a question and answer, and I can answer your question. And all of these subcluster support by logistic division, data and information division, and also health promotion division. We now entering the subtopic health reproductive subcluster. This is a part of health cluster, which is responsible for the availability and implementation of reproductive health services during health crisis situation to reduce the risk of morbidity and mortality in vulnerable groups. And the Ministry of Health policies on reproductive health services in health crisis situation. Reproductive health services in health crisis situation are implemented by a program called Minimum Initial Service Package or PPAM. We call it in bahasa paket pelayanan awal minimum for untuk kesehatan reproduksi. So this action managed by Directorate Health of Productive Age and Elderly below the Director General of Public Health in Ministry of Health. And this package is comprehensive reproductive health services also integrated into basic health services as soon as the situation stabilizes. So this is not immediate action after the disaster, but after the situation stable and everyone already replaced to the safe area, and we start these reproductive health services. And these reproductive health responses in disaster emergency situation are carried out by coordination with related ministry or other governmental institution, professional organization like Midwifery, and you all in this seminar should know about this, because we also have responsibility to take a role during the disaster. And also geriatric nurse, obstetrician, pediatrician, and also the epidemiology, environmental health, and everything. And also integrated with NGOs, because during the disaster, we know many NGOs comes to give us support to handle the crisis, and all related partners like supported by UNFPA through the reproductive health subcluster as part of the health cluster. So this reproductive health cluster is one of the activity in the health services in general. Minimum initial service package on reproductive health, or we call in bahasa PPAM, strategies are development of minimum initial service package on reproductive health guideline books. So we have a guideline, and also we already conducted socialization during the health crisis across programs and sector, especially in high-risk area. So we have mapped, we were mapping all location that prone to the disaster, and we conduct socialization and orientation, and also establish the team at the area, like a district team or provincial team, so we can do the mitigation action. And also we strengthening reproductive health subcluster with coordination meeting, monitoring, and evaluation, and this is at national and subnational levels. And also MISP RH training for trainer at national level. Directorate of Productive Age and Elderly Health already conduct the TOT, training of trainer, in this year 16 batch for this year, and next Monday we will conduct the last batch of PPAM training. And also this activity not only at the national and sub-national level, we also oriented the puskesmas, health worker, hospitals, public health officer, professional organization, and also we activation of the reproductive health subcluster and facilitating during emergency response and support for individual kids. So we drop the individual kits for reproductive health, like baby clothes, diapers, and for the menstrual hygiene kit, and also for elderly. The ISP RH is a priority intervention in health crisis situations. Based on statistical estimate, 4% of the population affected by disaster are pregnant women at a certain time. So we also faced the delivery in the disaster area. So we should build the emergency delivery room where the pregnant woman who having the in part 2 at the moment, we can move this pregnant woman to this delivery room, the emergency delivery room. And also 15 to 20% of pregnant women will experience complication in pregnancy and childbirth. This is the common prevalence. So we should ready how to take care of the emergency of maternal and neonatal. And 75% of the affected population are women, adolescents, girls, and also children. This is the vulnerable group during the disaster, also the elderly. And 19% of teenagers aged 7 to 19 years are at risk of experiencing sexual violence, child marriage, and human trafficking. This is also our concern because we don't have the permanent housing. We put them in a tent, and everybody can do the child abuse, sexual violence, and also human trafficking because they don't have mom and dad anymore because the disaster. So someone can take the children and bring the children to other place as human trafficking. And 27% of women in reproductive age 15 to 49 years need reproductive health services and hygiene kit during the menstrual period. We don't, at the moment, no market, no store, no grocery. So it's difficult for the girls and the women who had the menstrual period to get the diapers. And also 13% of affected population are toddlers. This is the children. And also 9.7% are affected population are elderly. So this is all the vulnerable groups that need the intervention, need the help and support for their daily life according to the reproductive health. And the urgency of these reproductive health issues in the health crisis situation. We should conduct the prenatal care, antenatal care, and delivery. We should provide the place and also the equipment, and also who will assist the delivery. And also we can face the malnutrition and maternal anemia led to high-risk pregnancies involving the preeclampsia, placenta previa, intrauterine growth retardation, or gestational diabetes, and so on. And lack of basic emergency obstetric and neonatal or newborn care at that time. This can increase the number of maternal mortality and also the newborn or neonatal mortality. Lack of access to contraceptive care, increasing the risk of unwanted pregnancy and unsafe sexual practices. How they can access the contraceptive medicine or the services. So we should provide this contraceptive care. And risk of gender-based violence and harmful practices. Women and girls become more helpless and vulnerable, increased risk of sexual abuse, trafficking, and prostitution, and unmet menstrual hygiene need. This is what I explained before, especially for women and girls, difficult to maintain proper hygiene during menstruation and minimum standard protection to ensure the health workers' health and safety during humanitarian action. We also should protect the health workers who take care of the victim of the disaster. The implementation of MISP-RH on each stage of the health crisis, pre-crisis, this is mitigation action. We established the reproductive health subcluster and development of related law and regulation. It's already done, and we have many regulation and development of norms, standard, procedure, and criteria like the guidelines, and also conduct the advocacy and socialization, training and orientation, logistic provision. So we should allocate the budget for logistic. So when the disaster come, we can provide this reproductive kit. And readiness assessment. We have tools to assess the readiness of the local government and also the team and also the people, the community to face a disaster. And during the crisis, we implementation of minimum intervention, this on all components that already I explained before. And post-crisis, we also conduct the comprehensive reproductive health planning and integration into primary healthcare services. So we provide the health services become in the situation that's a norm situation and increase again all activity to maintain the health of this population. MISP reproductive health components, we have 8 reproductive health services. First, we identify the coordinator of MISP-RH implementation and coordination mechanism. The second, prevent sexual violence and respond to the needs of survivor. And the third, prevent the transmission of and reduce morbidity and mortality due to HIV and other sexual transmission infections, and prevent excess maternal and newborn morbidity and mortality, prevent unintended pregnancies, and also provide the reproductive health services and engagement of young people, minimum health service for toddler and children, and minimum health services for senior population. This is all the activity, and we should have the comprehensive plan for sexual reproductive health services integrated into primary health care. And we do this at the post-crisis or during the recovery of disaster, and last, ensure the supplies to implement the MISPRH or the logistic. We already have the subcluster of health cluster, and for reproductive health subcluster, we also have the group according the intervention. We have 8 intervention, who is the coordinator and who will conduct the gender-based violence prevention, HIV and sexual transmission infection prevention, maternal and newborn health, unintended pregnancy prevention, youth engagement, toddlers health, and also senior or elderly health. How to identify the coordinator of MISPRH implementation and coordination mechanism? We identify the situation and personnel in charge at the local government, or who support from the NGO, from the district health office, and we conduct internal coordination, mapping, intervention design, and also work plan. And we also conduct the external coordination to health subcluster for other subcluster, and coordination with gender-based violence prevention with Ministry of Women Empowerment and Child Protection. And we continuing monitor and also periodical mapping of the victim, and ensuring availability of health workers, logistic, data, and information, and educate and spread information, health promotion of these reproductive health services, and also engage with the community. And how to prevent sexual violence and respond to needs of survivor. Reproductive health subcluster communicates to gender-based violence prevention subcluster, and the health subcluster coordinator about the needs and recommendation regarding action to prevent sexual violence. And ensure the availability of medical services and initial psychological support in organization or institution involved in disaster response, and ensure that there are referral pathway where we can refer the victim of sexual abuse and maybe rape, and how about the security and legal protection mechanism for survivor. Ensuring meaningful participation of women in refugee camps and related institution organization in the field, and informing about the existence of services for rape survivor. This is very important, with a telephone number that can be contacted 24 hours. Information can be provided through useful media, posters, and also banners. So we also provide the hotline 24 hours for rape survivor. This is very important, and ensure that there are competent officers to handle cases of sexual violence. How to prevent sexual violence and response need of the survivor. Excuse me, this is in Bahasa. We collaborate with police and also the social health workers to to conduct the violence victim services, and also we spread the information where they can contact if they have the sexual violence. The third, prevent the transmission of the reduced morbidity and mortality due to HIV and other sexual transmission infection. First, ensuring safe and rational blood transfusion activities carried out by institution, and emphasize the importance of standard precaution from the start of coordination and ensuring their implementation, as well as ensuring the availability and administration of post-exposure prophylactic antiretrovirals for HIV, and ensuring availability of condoms, coordinate with organization to prevent the transmission of HIV, and ensure the provision of antiretroviral drugs and all preventive medicine to prevent the mother-to-child transmission of HIV. We call it PPA, pencegahan penularan dari ibu ke anak. This is for HIV, syphilis, and hepatitis B. And support the provision of cotrimoxazole prophylaxis after the delivery for the baby, and provide post-exposure prophylaxis for the health workers and also victim of sexual violence, and ensure the availability of service and management of the infection disease, and post information with a 24 hours telephone number that can be contacted for continued antiretroviral treatment. So we maintains the treatment of the HIV person, the people with HIV during the disaster. And how to prevent excess maternal and newborn morbidity and mortality. We carry out mapping of health facility, community health center, PONET or basic obstetric and neonatal emergency care, and also comprehensive obstetric and neonatal emergency care at the hospitals, and building the referral system 24 hours a day and 7 days a week. So all time it should be ready to handle the emergency situation of maternal and neonatal, and ensure the availability of life-saving services post miscarriage. This is who have the miscarriage, so we should provide this service also, and we ensure the blood for blood transfusion, and data collection and mapping of pregnant women, postpartum and newborn babies in the refugee camps as soon as possible after the disaster, and ensure that officers can reach pregnant women and are placed in one place. So we gather the pregnant women in one place so we can give services more easy and comprehensive. And prevent unintended pregnancies with the providing contraceptive services, and also providing information, communication, and education material, and we ensuring the public knows about the availability of contraceptive supplies, so we can prevent the unintended pregnancies or unwanted pregnancies. And how about the reproductive health services and engagement of young people? We identify youth forums or youth groups or youth posyandu in the community, coordinate with the refugee coordinator regarding youth involvement, recruit youth cadres, and we have a youth forum of youth group. If there is no one yet, we can establish the youth forum and establish youth-friendly spaces in refugee camps facilitated, because the teenage need the privacy of the services. So we establish youth-friendly spaces in the refugee camps, and involving teenagers in providing basic information on adolescent reproductive health, including through youth-friendly space in refugee camps, and involving youth forum in logistic distribution, develop a youth forum activity plan, connecting with the organization of youth forum or youth group activities, and conduct focus group discussion. And for the minimum health services for toddler or under 5 years old children, we conduct the health services at the emergency response and health services for effective toddlers and service in refugee camps, like Manajemen Terpadu Balita Sakit, MTBS, or Integrated Management of Childhood Illness. And also we have the immunization services, giving zinc prophylaxis for the diarrhea, providing a balanced nutrition menu, and also environmental health, and prevent and deal with sexual violence and HIV transmission, carry out mental health service and psychological support. This is very important, how we can handle the children who face the disaster, knowing what happened with them, and we do some activities to make the children can release the tension because they face the disaster, and also ensure the logistic availability. And the minimum health services for elderly. In disaster situation, the elderly are at the high risk because some elderly people are multi-pathological and vulnerable to experiencing psychological stress in crisis situation, and requires health services because some of them have the chronic diseases and they need a chronic or long-term care and medication. And also they are risk of experiencing violence, such as neglected. Some elderly women cannot do anything, but no one helped them. And also how we can provide the proper nutrition for elderly, and ensuring the availability and accessibility of general health services and elderly reproductive. And also we providing health and reproductive health service, and also essential needs through multi-sector partnership. And for the comprehensive plan, we continuing expanding and improving clinical services, ensuring continuity of services and provide comprehensive reproductive, and expansion of MISP services into a quality comprehensive reproductive health program, and also get input from the community of the initial response to identify gaps, successes, and effort for improvement, and carry out long-term planning with the aim of integrating comprehensive reproductive health services into health system reconstruction effort. And we involving the health services, health workers, health information system, medical commodities, financing, and also governance and leadership as the principle of this comprehensive sexual reproductive health services. And we ensure all the 6 building blocks of health system already we provide the health services, the human resources, information system, medical commodities, including the vaccination, financing, and also governance and leadership. And this is the example of individual kits for affected population, like the blanket, the diapers, slipper, and the hygiene kit for menstrual period. This is for the pregnant women, newborn, the toddlers, teenage, and also the elderly. And we put the color for pregnant women green, postpartum mother orange, newborn baby red, back of this kit, so we can distribute to the refugee camp according the target population. And this is the material and guideline books. We have many guidelines, and we can afford this guideline with the barcode, and you can get the soft file of these guidelines. And also we have the minimum intervention standard calculator. How to calculate how many target at the population, how many pregnant women, how many the reproductive age women, and also the other affected population. We can put the location, what is the province and the district and also the sub-district, and we can get the number of affected population. So we can calculate how many kits we should provide and distribution, how many human resources, the health workers, and so on. And at the very onset of the emergency, these tools should be used to help coordinators and program managers determine affected population demographic for advocacy, fundraising, and programming. So we can put the location, and we can get the estimation number of the target, so we can advocate the other NGO, the central government or provincial government to give the allocation budget for this emergency response. And also we can do the information sharing, feedback, and also community participation during this humanitarian response. This is the cycle. We improve the awareness and encouragement to give feedback, and we also analyze the process and what is the action or the response of this condition. The participation spectrum, first we give information and also assessment, and we involve the community, and also we collaboration with project committee, and also empower the community to do the action plan. This is an example of the reproductive.
I'm so sorry, doctor. We cannot hear your voice.
I'm sorry. Accidentally I unmute my microphone. And this is the example for this subcluster who person in charge of this activity for youth, toddlers, elderly, and also healthcare facility and also logistic. Yeah, maybe that's all my presentation. I hope it's can give inputs, and I love to have question from you, and we can discuss about this minimum package of the disaster health services, especially for reproductive health. Okay, I give back to the moderator. The time is yours.
Okay, wow, such a great material. Thank you, Dr. Nida. All right, now we'll move to the question and answer session. We give the opportunity to a questioner. If you want to ask, you can write it down in our chat room by tell your name and write the question there. Is there any question?
Yeah, I read in the chat box from WOC. Yeah. May I read the question by myself?
Yeah, sure. Sure, doctor.
Yeah. First, let me introduce the WOC Niriana from Midwife Cirebon. The question is, what kind of prevention to prevent the occurrence of sexual disease in teenage today, apart from education and approaches? Because in my opinion, it is just about educating the public, still not effective. Okay, it's a great questions. So we have the educational package for the teenage. We call it, sorry, my laptop battery is running out. I need to recharge.
Okay, doctor, take your time.
Yeah. Okay. We have package for teenage that's called PKPR in bahasa Pelayanan Kesehatan Peduli Remaja, and also we have the Rapot Kesehatanku for the teenage. So in this package, we educate the teenage how to we educate about the reproductive organ, reproductive health, and how to prevent the disease that can affect it because the communicable disease or non-communicable disease, and how to prevent sexual abuse to the teenage. So, sexual disease is transmitted by sexual activity. So, how to prevent the sexual disease? We ask the teenage to protect themselves. Nobody can touch the sensitive part of the body, and if someone do the sexual harassment, the teenage should brave to say no or asking help from the people surrounding them. And so how to prevent the sexual disease? Don't do sexual activity if you are unmarried. So that's the message, how to prevent sexual disease among the teenage. Is my explanation answer your question?
I think Miss Osi can catch your answer, Doctor. Okay. Okay, Doctor, because our time is limit, we finished the question and answer session.
Okay, thank you for attention, and hopefully this short presentation can give many inputs, and I hope all the midwife from this faculty already ready to become a good midwife and can do many action if you send to disaster area to help the people, the refugee, to get the reproductive health services. Okay, I close my presentation. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. All right, the question and answer session is finished. Thank you for your amazing explanation, Dr. Nida. All of the question has been answered. Okay, before we end this session, allow me to read the conclusion about our discussion today. Okay, in conclusion, minimum initial service package on productive health strategies in health crisis situation. There are several things. Development the MISP reproductive health guideline book, socialization of MISP RH during health crisis across program, especially in high-risk areas, strengthening productive health subcluster, MISP RH training of trainer at national level, activation of the productive health subcluster and facilitation during emergency response and support for the individual kids. Okay, finally, now we have reached to the end of our first session of this seminar. I would like to say thank you to Dr. Nida as our speaker for the great seminar, and also to the audiences for the active participation. We got a lot of knowledge here. Okay, before we end this session, I would like to give a little present for you, Dr. Nida. For the IT, could you share the certificate on the screen?
Thank you very much for the certificate.
Okay. Okay, doctor, could we take some picture together?
Of course.
Okay, for all the participants, please open your camera. To IT team, could you help me for screenshot? Okay, we can screenshot this first slide. 1, 2, 3. Next slide. 1, 2, 3. Okay, I think it's enough. It's such a great time for us to having a discussion with you, doctor. Thank you so much, Dr. Nida. We hope you always healthy and happy. Lastly, I would like to extend my appreciation for all of us for learning together in this occasion. We will move to another session with the next moderator, to my partner, Jane Rahmawati. I hand over it to you. The stage is yours.
Okay, thank you very much. Good morning, ladies and gentlemen. Welcome back to the second session of the International Seminar on Midwifery Student Association. My name is Jane Rahmawati, and I'm going to be the moderator today. So, women and girls bear a disproportionate burden of disaster-related impacts. There are numerous explanations to gender impacts of disasters, including biological differences, gender discriminatory practices in relief efforts, lower access to information and resources, care responsibilities, and gendered poverty. Even though natural disasters such as the coronavirus pandemic have triggered numerous changes to the provision of maternity care, which is health services that are very close to women, many of which contradict the core tenets of what has come to be known as respectful maternity care. Additionally, there is mounting evidence that violence against women and girls is exacerbated during and after disasters. This includes rape and sexual assault, female genital mutilation, honor killings, and the trafficking of women, in addition to violence committed by non-partners or intimate partners. Exposure to disasters may also intensify pre-existing causes of violence against women and girls, including as gender and socioeconomic disparities, inflexible social norms, and imbalanced power structures in the home, community, and broader societal context. So, based on these issues, Poltekkes Kemenkes Tasikmalaya, as one of the health polytechnic in Indonesia, and the Midwifery Student Association wants to give a positive contribution for that to this conference. And for that, in this panel, we have two speakers who are already with us. We have Dr. Hazel Kidul, Doctor of Philosophy, Registered Midwife, and Mrs. Elliot Febriati, Master of Midwifery, Doctor of Philosophy. I'd like to greet Dr. Hazel Kidul as the first speaker. Hello, doctor. Are you here with me?
I am. Hello there.
Hey, welcome. And okay, now we're going to do our presentation till the next an hour and a half, and you, all the speakers, will talk around 30 minutes. And then after the speaker have presented the topic, we'll have a discussion for about 10 minutes each. And for your information, our audiences are faculties, researchers, and students also, so quite various background. And all the audience can ask a question. If you have a question, you can ask your question during the session by raising your hand, or you can type your question in the chat box, and I'm going to read them for you. Well, now, can we go to the first speaker? And I'm going to invite Dr. Hazel Kidal. But first, I'll read your profile first. Okay, so Dr. Hazel Kidal is a researcher. She is also a senior lecturer of nursing and midwifery in Western Sydney University, Australia. She pursued her master and PhD degree at Western Sydney University. She is currently a member of the Australian College of Midwives, a member of Translational Health Research Institute, and member of Australian Health in Preconception, Pregnancy, and Postpartum Early and Mid-Career Researcher Collective. She is also a member and mentor of the Maternal, Newborn, and Women's Clinical Academic Group of the Sydney Partnership for Health, Education, Research, and Enterprise. She has over 46 publications, 7 social media and Grey publications since 2021, and 24 podcast interviews since 2020. She also received numerous awards, prizes, and fellowships. And one of the most recent is her achievement in the 2023 Washington State University's Research Impact Competition. Okay, Dr. Hazel Kidal, are you still with me, ma'am?
I am.
All right, ma'am. Now let us get straight to your presentation. So please.
You happy for me to share my screen?
Of course.
Okay. Okay, can you see my screen now? Yeah. Okay, I will start. Well, thank you so much for having me here today. I always enjoy speaking with midwives and other healthcare clinicians across Indonesia. Today, I'm going to talk about respectful maternity care as an antidote to reduce violence against women in the maternity space. I'm going to cover 3 areas today: what respectful maternity care is, what it isn't, and how do we get there. First of all, what respectful maternity care actually is, because we do need to have an understanding of it if we're going to strive for every woman to receive respectful maternity care. In the UK, there is the White Ribbon Alliance, and they have put together the Respectful Maternity Care Universal Rights of Childbearing Women. And there are 7 rights, and these make up what is respectful maternity care. So the first one is every woman has the right to be free from harm and ill treatment. And in the white is the, I guess, the more simple term: no one can physically abuse you. Number 2 is information, informed consent, and refusal and respect for her choices and preferences, including companionship during maternity care. Basically saying no one can force you or do things to you without your knowledge and consent. The third one is every woman has the right to privacy and confidentiality. Sorry, I've just pressed the wrong button. 1 minute. Show the appellant, and then, sorry, I just got to move something out the way. There we go. Which means every woman has the right to privacy and confidentiality, meaning that no one can expose you or your personal information. Number 4, every woman has the right to be treated with dignity and respect, meaning no one can humiliate or abuse you. Every woman has the right to equality, freedom from discrimination, and equitable care, meaning that no one can discriminate because of something they do not like about you. Every woman has the right to healthcare and to the highest attainable level of health, meaning no one can prevent you from getting the maternity care you need. And finally, every woman has the right to liberty, autonomy, self-determination, and freedom from coercion, meaning no one can detain you or your baby without legal authority. I think it means a bit more than just that one as well. I'm basically saying that disrespect and abuse during maternity care are a violation of women's basic human rights. So respectful maternity care is respecting each of those 7 rights in women when they are accessing maternity care. Oh, sorry, wrong way. So the World Health Organization defines respectful maternity care as the care organized for and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth. But I'm going to ask you, do you think, I'm sorry, my controls are going all over the place. We're now going to look at what respectful maternity care actually is. And what is the state of respectful maternity care in Indonesia? I'm going to ask you, do you believe that all women accessing your maternity care systems across Indonesia are receiving respectful maternity care? Now, the information that I'm going to be drawing on today is from a study that I am the principal investigator for, which is the birth experience study. Now, in that birth experience study, we did a survey, a cross-sectional survey, which was online in Australia in 2021. We're now an international collaboration with 13 research groups across the world, including Indonesia, which is at its early stages, working and using our survey to find out about women's experiences across the maternity care systems. But back in 2021, we did our first survey, and it resulted in 8,804 women giving responses, and that means that they had done over 75% of the survey. We had 26 open text questions, where was a question where women could type their answers in. And that resulted in nearly 55,000 comments from women. We had 130 questions all up, covering all aspects of pregnancy, labour and birth, interactions with clinicians, decision-making, respect, postnatal care and breastfeeding. And we used a co-design method with representatives from 10 maternity consumer organisations across Australia that helped us design the survey, fundraise for the survey, disseminate the survey, and be every single step of the research process. So we can say that our study was designed by women for women. One of the things we found in our survey that 28%, so just under 1 in 3 women, reported experiencing birth trauma. So what is birth trauma? So this is what respectful care isn't. So now we need to really understand what birth trauma means. Birth trauma, I believe, is an umbrella term, and underneath there are lots of different areas that could result in the woman feeling she had a traumatic experience. She doesn't need to have experienced all of them. She may have experienced one of them. She may have experienced many, or maybe she's experienced something that I haven't put under the umbrella yet. We firmly believe that having a traumatic birth can only be identified by the woman. But it can include things like feeling a loss of control, being fearful for her own or her baby's life, experiencing physical trauma, which could be perineal trauma, but also trauma from a cesarean, a lack of support, and also obstetric violence, which is a particularly pervasive form of birth trauma because it breaks that trust between the woman and the healthcare provider. Here's a quote here from this woman who states that she felt ridiculed at times. I felt disempowered. I walked away feeling less like a woman and left to mother my new baby and my other 2 young children. I was just looking at my slides, not quite I thought they would be. But then we know that the experience of birth trauma is impacted by the type of birth a woman experiences. And in the birth experience study, we explored the impact of mode of birth on birth trauma. And we found significantly higher birth trauma rates for women who had a cesarean during labor or instrumental birth compared to women who had a vaginal birth. Women who had a cesarean before labor had the same birth trauma rates as the overall rate of 28%. So here you can see on these little tiles here that the highest rates of birth trauma were with women who had a cesarean during labor. You may have different terms for that. You might see that as an emergency cesarean. And then it was women who'd had an instrumental birth, so a forceps or a vacuum birth. And then it was the cesarean before labor, but actually the only mode of birth that decreased birth trauma rates was a spontaneous vaginal birth. And that was right down to 15%. And that's important to know when we're trying to prevent birth trauma. Then really we need to be focusing on encouraging and facilitating women to have a spontaneous vaginal birth. There was also an impact on birth trauma by induction of labor. Now, I'm not sure about what your induction of labor rates are across Indonesia, but they are skyrocketing here in Australia, as they are across much of the high-income countries. We are seeing with the introduction of policies that almost over 40% of first-time women, first-time mothers, are actually being induced, which seems a very high number. So we looked in our study and compared induction of labor to birth trauma. And we found significantly higher birth trauma rates for women who were induced compared to a decrease for women who went into labor spontaneously. And you can see that here. So an induction of labor raised it from 28% being the norm up to 38%. And yet, if the woman went into spontaneous labor, that was down to 23%. And here's a quote here. "My labor was induced. It was too hard to handle. They did not ask or listen to the birth plan. And I didn't get the physiological placenta birth. They also placed in the Cinto while I was asleep from the epidural without my permission." Now, to be able to get consent, you don't get a one-off consent during labor. You need to get informed consent at every single time that you are doing something to the woman. And that includes putting up Syntocin on. So she should have been awake to be able to give consent for that to start, even though she may have given it previously. Then there's obstetric violence, and certainly this really interesting seminar series has been looking at violence against women. We found in our survey that more than 1 in 10 women reported experiencing obstetric violence, and it was the first time we had asked that of women in Australia. 626 comments were left by women who experienced obstetric violence, and we did an analysis of those comments. And what we found was that there was 3 main categories. Women expressed feeling dehumanized, powerless, and violated. In fact, I believe that they are on a continuum, and it's almost a process that gets to the worst type of violence, which is the violated, so the comments that were included in the violated. But I feel they go through a process of being dehumanized. That makes them feel powerless, and that makes them then more vulnerable to be violated. And I think that is something that as healthcare providers, we do to women. We make them feel dehumanized. We take away their power, and then we may do the violating. It is not a favorable topic to talk about obstetric violence, and many people, including our medical colleagues, get upset when we talk about obstetric violence. But it is imperative that you understand that the term obstetric violence does not just mean doctors. It means any healthcare provider in the maternity space, and that includes you, whatever your role is. Here you can see a quote. "The obstetrician pulling my placenta out aggressively without giving me the option to birth it, telling me to be quiet." I'm going to ask you, and maybe if you feel brave enough, pop this in the comments. Have you experienced obstetric violence? As a student, have you witnessed this? As a midwife or a doctor, have you witnessed this? Have you worried if some of your practice could be this? If you have an example, please do feel free to share that. So I'm just looking for my little thing that's going to tell me which way to go. Oh gosh, that went way far back, didn't it? Okay, I'll keep going. Finding my right slide again. Here is another comment about obstetric violence. And this is what's actually in the paper. I'll give you the link shortly. In this comment, the woman says, I felt dehumanized because A, nobody told me the procedure was optional or gave me choice to opt out. B, I was very clearly highly distressed and they didn't pause or stop the procedure to check my consent. C, there were 3 people I didn't know standing and looking at my exposed naked body. And D, the midwife had joked about the procedure. You might be wondering, what is the procedure? My answer will be, it doesn't matter. At this point, it only matters how the woman experienced it and reflects on it. Here's another comment. The vaginal exam where I did not consent that went on for over 5 minutes as I was held by my wrist and told to sit still and be a good girl, while I yelled no and to stop repetitively while moving up the bed. Obstetric violence is wrong and we need to reflect on our own practices and on others to ensure that women are treated respectfully. And we cannot have an environment of respectful maternity care as long as obstetric violence exists. If you want to learn more about obstetric violence and what we wrote about it from the birth experience study, please scan this QR code and it will take you to the paper, which is open access and was published in December 2022. So it's now having its 1-year birthday. Another area that we look at is mistreatment. And there can be a crossover between mistreatment and obstetric violence and birth trauma. In the birth experience study, we include this mistreatment index. And the mistreatment index is a series of 7 items. You can see the statements there. And the woman answers yes or no to experiencing them. If she experiences any of them, then she has a positive mistreatment score. In our survey across Australia in 2021, we found that 35% of women experienced at least one type of this mistreatment. 18% felt that they were ignored by clinicians, and 2% experienced physical abuse. And although those items might have fewer yes responses, the fact that respondents indicated they had experienced any physical abuse, such as aggressive physical contact or inappropriate sexual contact, is a cause for concern and matches with the comments that the women left around obstetric violence. I ask you today, if you were to look at those 7 items and think about the women that you have cared for in the past, do you think they would be able to say yes to any of those 7? And if they could, what do you think the rate of mistreatment of experiencing one of those 7 would be in Indonesia or even in the place that you work? And if you think that women are experiencing this, what do you think you could do to reduce it? We looked at the impact of certain groups across Australia, groups that are maybe a little bit more vulnerable. One of those is our First Nations women or Aboriginal and Torres Strait Islander women. And across Australia, we know that our First Nations mothers have higher rates of premature birth, perinatal deaths, and a lack of birthing on country options. We explored the prevalence and experience of birth trauma and obstetric violence for First Nations women in our study and found that First Nations women had significantly higher birth trauma and obstetric violence rates. Do you think there are groups of women across Indonesia that might be more vulnerable to experiencing birth trauma and obstetric violence, maybe due to a decreased status in society? What about the groups of women that have lower socioeconomic opportunities, lower education, are younger or are unmarried? How do you feel they would experience birth trauma and obstetric violence? We can see here that it went from 28% to 37% of birth trauma for First Nations women. And instead of more than 1 in 10, it was more than 1 in 6 experiencing obstetric violence. This is a problem that we need to work on. Another area is for women, or another group of women that are more vulnerable to experiencing mistreatment, birth trauma, and obstetric violence, is women who are from culturally and linguistically diverse backgrounds and or are migrants to Australia. Across Australia, we have a high migrant background. Over 40% of women who had a baby in 2021 were born overseas, with the top 4 regions being Southern Asia, Southeast Asia, Chinese Asia, and the Middle East. That includes women from Indonesia. The experience and prevalence of birth trauma for women from cold and migrant backgrounds was explored. We actually put the survey in 7 other languages. You'll see it's not in Indonesian, but we were choosing the top languages that were seen as the migrants coming in. So Indonesian just went below that. Migrant women from non-English backgrounds had higher birth trauma and obstetric rates than those from English-speaking backgrounds. And here is a comment, I believe, from Farsi, which was this woman saying that she had severe physical and mental damage. And then young parents. Our young women rate of 24 and under is lower, I can imagine, than Indonesia, but they still do have higher rates of perinatal deaths. So 15.8 per 1,000 versus 8.8 for women over the age of 24. And we then found that they actually had the highest birth trauma rates out of the different populations that we looked at. Look at that, it goes up to a whopping 41% of birth trauma. And again, a 1 in 6 of obstetric violence as well. So how do we move from birth trauma, obstetric violence and mistreatment, which is not respectful maternity care, towards having respectful maternity care for every woman, baby, and her family? First of all, what we need to do is we need to listen to what women actually want. Have you done that? Do you have that data across Indonesia? Do you actually know what kind of maternity services women want? Often as healthcare professionals, we would like to take that knowledge away from women and say, well, we know what women want. We will design the service that we think women want. But actually, guess what? As the majority of us probably on the screen are women, women are extremely smart and capable and able to tell us the type of maternity service they want. In our birth experience study, we had a question that asked women, if you were to have another pregnancy, what would you do differently? And this is what this slide is about. We had a paper that came out just a couple of months ago in the British Medical Journal Open. And you can see down here, there's a little scan. You can scan that and link to the paper. And we had a conversation article, which is a shorter version that you can scan for there. What we found that there was these 4 categories that women really talked about. First of them was, next time I'll be ready. And on this, you can see just a little, it's a very big table, but this is just a little section of it. That under that first subcategory of next time I'll be ready, women were saying that they want to prepare themselves better next time. And they're going to be more knowledgeable and confident. The next category was, I want a specific birth experience. And women really identified that vaginal birth was what women wanted, especially if they'd had a previous cesarean. And from the next level down, the biggest amount of comments were actually women having to have access to home birth with a midwife. Now, home birth across Australia is very small, probably 1 to 2% of women are accessing home birth across Australia with a private midwife. So it's very low. It's slowly building, but it's still very low. However, that was the one with the biggest amount of comments in it. So women are obviously really wanting it. Women also spoke about the specific model of care they wanted. And the top one was midwifery continuity. And especially then actually having the option to have a private midwife. So what I mean by continuity of care is having the same midwife through pregnancy, through having appointments, all the antenatal appointments with the same midwife or small group of midwives, having that same midwife available and on call for labour and birth and being there for labour and birth, and then seeing that midwife in the postnatal period. And with private midwives, that can go up to 6 weeks. In the public system, often about 2 to 3 weeks. But having that midwife visit at home. That is the model of care that we know reduces premature birth, reduces perinatal death, reduces unnecessary interventions, and increases women's satisfaction. That's from the studies and the systematic reviews. But from this, where we had nearly 7,000 women leave comments to this question, we can also see it's what women want. And finally, women wanted better access. And I think this is something that you'd be able to think about across Indonesia, because across your archipelago of different islands, you will have a variety of access to maternity care. And some women are having to travel on boat by quite some distance to visit care. And in Australia, although we don't have that by islands, we have a very big landmass. We have many women in regional, rural and remote locations who don't have access to maternity models of care, such as midwives, yet they really want it. There's a couple of quotes there that you probably had a chance to read now. So how do the different maternity models of care impact birth trauma and obstetric violence and mistreatment? We looked across that in our study, and that's where we've got this rather complicated graph, but let me explain it to you. Down the bottom, we have the different models of care. Standard is when the woman sees, goes to the hospital, might see a different midwife or doctor at every appointment, and then has whoever's on labour ward caring for her during labour and birth, and whoever's on postnatal ward caring for her postnatally. GP shared care is when you might have a doctor, a general practitioner who works in the community, maybe does the pregnancy care in the community, and then she goes into the hospital like standard and has different people there, fragmented in model. Private obstetric care is exactly that, when a woman has a private obstetrician. So there is that continuity of care, and often that can be in a hospital, private hospital. But that doesn't mean that they have the same, the obstetrician there supporting them through the labour. That's often midwives at that point. And they don't really provide postnatal care, such as breastfeeding advice and visiting in the home. A midwifery group practice is that continuity of care with a midwife in the public healthcare system, and a PPM is a privately practicing midwife where they do the same continuity of care, but in the with maybe accessing home birth, or they've paid for that midwife. What you can see across those 5 different models of care is that these lines are the standard rates we found from the whole population. And it's not until you hit the continuity models that they start decreasing in birth trauma, mistreatment, and obstetric violence. And the lowest rates of all of them were with privately practicing midwives. So we can say that continuity of care models have less reported rates of birth trauma, obstetric violence, and mistreatment, with the lowest reported rates being women who hired a privately practicing midwife. We then look at mode of birth. And we look at that, we're crossing over a few things. Remember earlier, I showed you that spontaneous vaginal birth had the lowest birth trauma rates, and yet cesarean during labour, emergency cesarean, had the highest birth trauma rates. But how about we superimpose the model of care onto the type of birth? And there we can overwhelmingly see that the green one, which is vaginal birth, is highest, with continuity of care with a midwife, both in the public and in the private system, and lowest with a private obstetrician. So if we know that birth trauma rates are higher with continuity and birth trauma rates are lower with vaginal birth rates, then we can see that the best chance of not experiencing birth trauma and maybe then receiving respectful maternity care is with continuity of care with a midwife. So then we need to think about what is it that women actually say about these different models of care. And I'm very excited to share with you because this paper has just come out, but don't share it on social media yet because we've got a media release coming out next week on it. We asked women about their experiences in their different models of care. And then we counted and looked at the amount of strengths and limitations that each model of care had. Standard maternity care had very few strength comments, which are positive comments, and high limitation comments, so negative comments. And however, in Australia, it's 40% of models of care that actually provide standard care. Please, I can't see comments, so if somebody wants to tell me when I'm close to time, please do let me. Then high-risk maternity care is when a woman has been designated as high risk and then is seeing different doctors every appointment in the public system. That is the one that had the highest amount of negative comments and the least amount of positive comments. And not too many women experience this, but it's still there. And sorry that that quote hasn't quite come through there. So my slides have taken a while to load up. GP shared care, again, same pattern, very high amount of limitation comments or negative comments and a lower amount of strength comments. Midwifery group practice, you can start seeing the numbers changing now. There was almost half and half of strength and limitations. And yet, you know, about 15% of women across Australia get access to this type of model of care. I think the limitations are there because it's still within a public model, and that means there can be a lot of policies and guidelines that have still got to be followed, and they might not always be able to have the midwife that they know. That midwife might not be available on the day when they go into labour. With private obstetric care, we've got more strength and less limitations again, and it's about 11% of women have access to this across Australia. The comment that unfortunately is not coming up is a really good comment, because what it shows you is, however, the woman really appreciated and had respect for her private obstetrician. She felt that what was missing was that empathy, was that relationship-based care that maybe she would have got with a midwife. And then the model of care that overwhelmingly had the highest amount of strength comments and the lowest amount of limitation comments was privately practicing midwives. And this is when women can access a midwife, their own midwife, they're paying for them. So obviously this is a limitation to many women. And they can also have the opportunity to be able to have a birth at home with a highly skilled and trained midwife. But as you can see, it's a very low volume of women that have access to this across Australia. So if you want to read more about this paper has literally just come out, and it's a very exciting paper around, you know, what women were saying about their different models of care. And it's based on just under 3,000 comments that we analysed. So again, I apologize, some of my pictures are not coming through. But one of the other things that we need to look at when women have experienced a previous traumatic birth, whether that be in the actual, straight away, like the labour and birth they've just had, or in a previous pregnancy, is we need to be able to debrief with women and give them the opportunity to get some counselling and talk about the experience they went through. And I ask you today, is that something that is experienced across Indonesia? Do women have the access to speak to someone about their birthing experience? And if so, who do they speak to? In our study, we asked them about debriefing, and we found that just over half of women stated that they did have an opportunity to talk to somebody. And 47 of those women spoke to a midwife and 23% spoke with a doctor. However, from the 48% that didn't get to speak to someone, they would have wanted to have the opportunity to speak to somebody if they could have done. So what we did, and this is a different paper that we're now working on, hopefully should be published next year, is we analysed their experiences of what it was like to speak to somebody. And what we found is that we could categorise that into unhelpful debriefing and helpful debriefing. So 2,158 women left comments about their debriefing experience. Now, when we look at unhelpful debriefing, and basically this is what not to do, they found that healthcare providers used defensive language, really saying, well, you know, this is why that happened, and you know, you're just lucky that I was there that day, and if this hadn't happened, it would have been terrible. And women don't actually want that. Women actually just want a better experience of being able to be heard, not just to hear all the reasons why. Another unhelpful debriefing experience was if it was rushed and there was no opportunity for the woman to speak and be listened to. Women also identified if there was no resolution. So it was a conversation that didn't have an ending, that didn't help the woman feel that she got more understanding of what happened or had the opportunity to explore that through talking. And number 4 was when healthcare providers just turned around and said, well, okay, so you may have had a traumatic experience, but at least you've got a healthy baby. And that actually isn't a very helpful debriefing style, so please don't use that. And here's a couple of unhelpful debriefing quotes. A lot of counsellors are unprepared to deal with real birth trauma. Phrases like, but your baby is healthy, or let's just focus on the positives, are not conducive to healing. A different OB, obstetrician, came to see me 24 hours after the birth to discuss how my cesarean went. It was a very quick, brief chat, about 5 minutes, and I was so tired and drugged up on endone that I barely remember it. I would have liked a more in-depth discussion while my partner was present, and perhaps a couple of weeks later so I could retain the information a bit better. So how can you do helpful debriefing? Because I firmly believe this leads to respectful maternity care, and it's part of respectful maternity care. So the women identified that they got the opportunity to ask questions and get clarity. So I had a cesarean. Can you tell me why that happened? Why did we have the induction? The CTG was saying that the baby's heart rate's gone down. Why did that happen? And then to be able to get the facts, get the information so that women could understand what it was that happened to them. Women said, I was given time and I was listened to. That's really important. And so if a healthcare provider, maybe a doctor, does not have the time to sit down and talk, maybe that's not their job. Maybe this is the job of maybe a midwife who could spend a little bit longer. And if we're not thinking on the postnatal ward that this is important and we're too busy and too rushed, then do we need another role for this? Do we need someone else who is allocated to do this, plus has good training in it? It helped process my emotions. That's another helpful type of debriefing that happened, where a woman could kind of go through and be acknowledged that she may have been fearful at that time. She may have been scared. She may have been worried. She may have been angry. She may have been upset. And that's okay. Give her the opportunity to process them. And finally, a good debriefing helped her plan for the future. When you've got an understanding of why something happened, you can then have an understanding if there's a likelihood it might happen again. Or maybe you might want to just change your options so that because you've got that deep understanding of what happened. There's a couple of quotes there. After all 3 of my births, my midwife sat down with me and we discussed my birth. She explained different parts and I was able to ask questions. I didn't know this, but because I knew and trusted her, I followed her lead and she looked after me. It was only after when she explained that it made sense. So that's all one quote. I've just pulled out a couple of bits from it. So my key points from my entire presentation, remember, we looked at what respectful maternity care is, what it isn't, and how can we get to achieve respectful maternity care. Here are my 3 points, and there were some beautiful pictures there, but unfortunately they've not loaded up. The first one is respectful maternity care is a human right. and women deserve to receive care that is free from harm. And what it isn't is that more than 1 in 10 women are experiencing obstetric violence, 1 in 3 experiencing birth trauma, 38% of women experience mistreatment all across Australia. That's what respectful maternity care isn't, and that's what we need to work against. And finally, how do we get there? Is that women actually want continuity of care. They want less interventions, and they want to be heard. My question for you is, does that happen in your workplace? Does that happen across Indonesia? And if not, why not? And then finally, please stay in touch. I have an Instagram account, and I love having people on the Instagram account and messaging me and talking to me about research. If you have any questions from today's presentation that we don't talk about in the panel, then please do scan my QR code on there. Come and follow me on Instagram for little videos about research, stay up to date with research in Australia, the research that's coming out of our birth experience study and our international collaboration. So get your phones out, scan that code right now, and start following me on social media. I'd love to see you there. And that's the end of my presentation. I'd like to hand back to the moderator.
All right. Thank you. Thank you, Doctor. I'm fascinated by how you emphasize that respectful maternity care is basically a human right, that women have the choice and the power to choose and the right to be heard about how they feel, what they want, as well as their right to know and gain clarity. I couldn't agree more. And I think as Indonesian, it's so much relate with us. And yeah, we will move to the question and answer. Actually, Doctor, we have so many questions, but
Excellent.
as we know that we run out of times, so I think we have just one question for you. So as I listen to your explanation, I believe that to realize respectful maternity care, many things must be considered, including actors, whether they be governments, health profession associations, international bodies, or individual health facilities, etc., etc. However, for some regions of the country, such as Indonesia or most countries in Asia, we still have a strong patriarchal culture. It is still very difficult for women to be able to choose and determine matters relating to themselves. Most of these decisions are left to their partner or their families, even when they conflict with what they want, the woman wants and needs, especially in receiving maternity services. It's as if a woman's body doesn't belong to her, and that's kind of sad.
Yeah.
So the question is, in such circumstances, what should midwives as health workers do to ensure that the respectful maternity care can still be fulfilled? Because, you know, in many cases, women are not ignorant or clueless, but they unable to do so.
Absolutely. And we still experience a patriarchal hospital system in Australia as well. And we have very high rates of intimate partner violence, and we lose more than 1 woman a week to who dies as a result of intimate partner violence in Australia. I think we've reached up to 70 women this year. So we understand it is a very difficult time for women to actually speak up for themselves. And we have maybe a little bit more say here than you do across Southeast Asia and Indonesia. But I do believe that midwives have intense power. Throughout history, midwives have been there. In every culture, in every corner of the world, there has been midwives in every single community, and that includes Indonesia and across Southeast Asia. And what midwives can do is that we can break through that patriarchy and connect with women, because we are predominantly women, and we have a philosophy of women-centered care. Now, as a profession in Indonesia, you need to work together to start seeing midwifery continuity of care models come out. You have a very large amount of midwives in Indonesia. That means a large voice, a big, powerful voice. And the evidence shows that midwifery continuity of care decreases all the things I said earlier, but also decreases trauma, increases respectful maternity care. As a midwife, you have the opportunity to sit and talk to that woman, maybe even without her partner, and talk about the options and support her. And you can be that advocate for her, even if you've only ever met her once, or if you've got that continuity of care relationship. But honestly, I would love to see more continuity of care programs, and you have some coming across Indonesia because they break down the patriarchal system and build up women-centered care.
All right. Thank you very much, Doctor, for your answer. Actually, we still have so many questions here, but our time is limited. So I think maybe any participants there that have more questions for you can DM you or anything. Is that okay,
Yes,
Doctor?
please come to my Instagram account. I'm happy to answer questions there.
All right. Thank you so much, Doctor. And that's it, Doctor, for this session. But before we finish the topic, we would like to give you a certificate of appreciation, and we want to invite you to take a photo session together with all of the participants. Is that okay?
Absolutely.
All right. So please to IT team. So here's the certificate of appreciation. And then, all right, now can we
Cassie, for
take
that
photo
certificate.
together? Okay, Doctor. So for all the participants, can you open up your camera and we will take the picture in 3, 2, 1. For the next slide, in 3, 2, 1. All right, that's it. Thank you very much, Dr. Hazel Kidul, for joining with us. You know, Poltekkes Kampus Tasikmalaya, my college very much appreciated. I hope we can have any collaboration in the future together too, as a midwife and as a college also. So
Thank you very much.
all right.
Terima kasih.
Thank you very
Have a
much.
wonderful rest of your seminar. Thank you for having me here today.
Thank you so much. All right, ladies and gentlemen, that's for the first speaker in the second session. And now we move to the next topic that will be presented by Mrs. Alit Pabriati. So, ma'am, are you here? Mrs. Alit Pabriati, ma'am, are you with us? Okay, as we're waiting for her to be ready, I'll read Mrs. Alit Pabriati profile first. All right, so Mrs. Alit Pabriati, Master of Midwifery, Doctor of Philosophy, is a lecturer in Midwifery Department at Poltekkes Kampus Tasikmalaya, Indonesia. She pursued her PhD degree in Health Social Science at Mahidol University, Thailand, and graduated from Master degree in Midwifery at Pajajaran University, Indonesia. She is a doula of North America Certified International Doula since 2015, and also a review for Malahayati Midwifery Journal and Sajpub International Journals. All right. Hello, Mrs. Alit Pabriati. Have you joined us, ma'am? Good morning, Mrs. Alit Pabriati. Oh, I'm so sorry. We couldn't hear your voice.
Hello, good morning. Sorry for that.
Right. All right. How are you today, ma'am?
I'm good, thanks. How about you?
All right, nice to hear that. All right, ma'am, it is your time to present your topic, and you have around 25 minutes. So
Mhm.
please.
Okay. Let me change my screen. Okay. Are you seeing my screen now?
Yes, we can see your screen.
Okay, so hello. Good morning, everyone.
Morning, good morning, ma'am.
Yeah, it's all my pleasure to join today's conference. My background is health and social science. So today in this opportunity, I will present about prevention initiative and protecting victims to end violence against women. I will start it with addressing violence against women. So basically, violence against women is a gender-based violence. We can say it's any act that violates the right to physical or even someone mental well-being. The form of violence against the woman itself can so vary. Yeah, it can be online or even offline actions, and language expression and also gesture toward a woman that indicate any sort of discomfort with sexual. It's also considered as violence against women. Okay. I would like to break down my presentation today, become three main topic. So the first topic is the fact about violence against women and what challenge we face to end violence. And the last topic is what is our rules to eliminate it. Okay, according to WHO, 1 in 3 women throughout the world, around the world will experience physical or even sexual violence by a partner. As you can see, highest incidence was happened in Southeast Asia region, where Indonesia is a part of it. Yeah. Likewise, our national data also saw an increasing trend of incidents violence against women during 2008 until 2019. The latest data, 2022, our National Commission on Violence Against Women has recorded that they receive at least 17 reported cases per day. Can you imagine 17 reported cases of violence against women happen per day? And the characteristic of the victims remain the same. Those who are young age with lower educational level tend to be a victims. Surprisingly, 8.6% abuser are people who are expected to be protectors. I mean, it's such as a teacher or even a policeman or even a public figure can be abuser. Another fact is the most major form of violence against women is sexual violence. Women are more likely to be harassed, assaulted, and killed. During 2023 itself, we already there are about more than 2 cases, 2 murdered woman cases happen in Indonesia. Abusers are usually the intimate person, such as her husband or even her boyfriend. Violence itself can happen regardless of socioeconomic status, religion, or ethnicity, which means every woman has an equal chance to be a victim, no matter she is poor or rich family. She is having a same or equal chance to be a victim. Last fact, there is no really safe place there is no really safe place considering to avoid violence against women. I mean, violence against women can take any place at any public or private place. So there is no really a safe place. There are several challenges that we face to end violence against women. The first challenge itself is victims often face obstacles to claim their right and seek redress. If you ever heard about 4 years ago, around 4 years ago, there is a case about a violence at the workplace. If you notice, it's a woman were raped by 5 colleagues, yeah, by 5 person, yeah, in her workplace during work travel. And when she tried to report the case, before she can report it to the police, the company itself already treat her to not report the case. And when she decided to report it, and she finally made a report to a police, an ocnum from a police officer just simply advised her to marry one of one of the ocnum who raped her before. Can you imagine how sad is it when you were pushed to marry one of abuser? Yeah. There is no finally jurisdiction process took a long time. It's a long process before it finished. Can you imagine how her mental state is down due to negative stigma or else? And when the law is set, another challenge is how we implement the laws itself. We can't do it by ourselves. We need a greater collaboration of interlinkages between sectors and actors. So we still need a lot of human resources who are good on it, yeah, on handling of violence against women. As third challenge, based on research done in Java, 2001, a theme emerged that that the victim choose to silence for their harmony, for their family harmony. Yeah, while in some parts of the world, women feel more empowered and more willing to fight for their right. Here in Japanese, yeah, women remain silent due to social stigma and lack of supportive environment. One opinion comes from the respondent. She said that the norm, the expected rule of being a Japanese woman is to follow anything that her husband said. And another rules, as a husband, he has obligation to discipline a woman. So every time her husband doing physical violence, she cannot do anything because the expected role that she have as a woman, as a wife, she must follow anything that her husband do or her husband say. So it's still a biggest challenge for us. It cannot change fast. Yeah, we need a process to change it. Yeah. And the last challenge is violence against women itself is triggered by the existence of patriarchal culture and the expected role of being a woman. Yeah, a few years ago, we still we still face child marriage, or even a woman who are giving birth for about more than 5 children. We can still face it, right? Yeah, it's one of it is caused by a patriarchal culture. Some of women were forced to give birth more children. Yeah, they have they have some what we call it, some pressure that more children is more wealth. Yeah, it's something that's not true, of course, but it's really happened. Or even in some part in Indonesia, to inherit someone wellness, we need a son. Yeah, we need a son, not a daughter. So when woman gave birth to a daughter, until she able to give birth to a boy, it won't stop. So she was pushed to give birth another son, another baby, until they get a son. Now, what we can do to eliminate violence against women? First, we cannot do it by ourselves. Please say no and be united. Yeah, unite it to end violence against women. There are several steps that we can have. We can try to eliminate violence against women. The first step is raising awareness regarding violence against women. Of course, we need to educate women so they know their right. Some of us didn't know about our reproductive health rights, or even we don't really understand how to address violence against women. We may obey of it. We didn't think that is a that is a form of violence, but in fact it is a form of violence. For example, yeah, for example, have you ever experienced that when you when you pass in public place? Yeah, there is an eyes who follow you. There are eyes who seen you from top to the bottom of your body. They seen you like that, but you think it's just a common expression, or even it's just maybe you think that I'm beautiful, but it's not simple like that. It is a form of violence against women, where a gesture or where their expression is expressing violence against women. So before, if we stay with of it, I'm sure that there will be more risk to have to be a victim. So you can choose to speak out about it. The second way is to engaging men, of course, because the abuser is usually men. We need to engaging men to solve it. Yeah. What we can do as a woman, as a mother, or even a mother to be, from now, you can start to teach your boy, your son, that violence against women is crime, is one form of crime. You can start to teach your son that we need to respect a woman. The last, of course, we need to mobilize community to take responsibility for ending violence. According to our law, family, society, and community, all of us has the same obligation to end violence against women. One thing that we can do is to to provide a safe environment for a woman. Or maybe we can work together to what we call it. We can work together to raise awareness regarding violence against women. Okay. Next, what we can do is promote women empowerment. We need to enhancing women's sense of self-worth. Yeah. Every woman deserves to be loved unconditionally. Every woman is precious. Yeah. A research in Jakarta showing an evidence that 15% of high school girl in Jakarta were experience violence. They were forced to do kissing, or even the worst thing is they were forced to do sexual intercourse when they have a relationship with their boyfriend. Now, if you have a boyfriend that treats you like that, please leave them. Yeah, you are worth. You deserve to be loved unconditionally. If he say that, it just action to show your love, don't do that, please. You need to say, you need to raise your sense of self-worth. The next step is to increase women's ability to determine their own choices. To gain opportunities to speak up for your own choice, you need to achieve high-level education, sharpen your talent, and those things will equip you to gain power and better position at society. Then you will be able to decide to become a decision maker for your own self. Maybe around this year and last year, we heard about the case about Vena Melinda and Leslie, right? Those two public figure has become a victim of violence. Yeah. But because they have a better position in society, they have a power to report the case. They're lucky to have a power to report the abuser. So it's make the abuser become promise to not doing the same mistake again. They can fight for their justice. But can you imagine someone with not even having a better education? She may silent for it. She cannot determine what their own choices. Okay, so when you have a better position at society, at the same time you will raise your capability to influence social change also. The next step is harnessing community responsibility. Now, in our community, there are several movements. There are several actions taken by government or even local community, such as woman and child-friendly village, child-friendly school, or another woman organization is flourish now. Please support them. If possible, you can be you can be a part of it. Next thing is Next thing is how to reporting a case of violence against women. If you are a victim or you are a witness or you witness it, first thing you can do is find someone to talk. Ask them to be your guardian. Yeah. And ask for their help to collecting the evidence. After those things are settled, you can report it through online or offline channels. Call 129 hotlines or just text it through their their WhatsApp, or report it through application S4P and Lapor. After you report the case, you will immediately receive victim protection procedure. You will get consultation from the physician. You will get medical care, or even you will have victims. You will have a shelter for you, and you will get any help to enforce the law, also to social rehabilitation. So now, if you are a victim or witness it, please report it. The procedure now is more simply than we have before, so you can easily report it. The last step is actualize restorative justice. What does it mean? What does restorative justice mean? It is a process which brings victims and offenders into contact and provides an opportunity for victims, offenders, and sometimes representatives of the community to discuss together how to repair the harm caused by the case. Please avoid your education process which is far away from victims' protection, which blame the victims for the crime happened to her, which having negative thought about the victim as a part of crime. Please avoid it, because we still face it when someone report it and then it goes to the adjudication process. All Indonesian netizens having a negative talk about them, that she is the one who insult the crime, like that she is also has a responsibility. She is a part of crime because she may initiate a crimes or any. So please avoid it. Now, when you want to have to express your opinion, please consider about the victim's feeling also. It's not a simple things for her to report the case. It's a complicated for her. Okay, sorry. Last, we need to allocate resources to address the violence against women. So violence against women, like I said before, it's also sustained by lack of accountability at the individual, community, and government level. For example, the number of counselor we have to help you in shelter program is still not equivalent with what we need. So we will need more of a counselor in this area. So we still need to allocate resources. So we can allocate resources to program research or to strengthen our institution and capacity of the health, education, law enforcement, and social services sectors to address violence against women. Remember, together we can end violence against women. Maybe that's all for today. Thank you very much for the opportunity.
I couldn't agree more how you pointed out that we should engaging men in raising awareness regarding violence against women. It is really remind me to the UN's campaign that called He for She that launched more than 9 years ago. And it's quite painful knowing this issue still occur until this time. So it's our duty together to take action, both men and women. All right, we move to the question and answer, ma'am.
Yeah.
Actually, we have so many questions, but again, I think we just can answer just one question. So the question is, as you say it before about, blaming the victim, or we tends to, call it victim blaming. In so many cases, society keep blaming the victim, especially women in sexual harassment cases. They keep pointing out the victim's body language, and then talking about how the victims dress, or even compare the situation as an ant that attracts to sugar or sweets. So what should we do about that? Because we are, most of us is our midwife, so what should we do about that, both as a part of community and also as a health workers?
Okay, that's such a great question. Okay, how to avoid blaming fiction due to their appearance? Okay, so first, just be yourself. You don't need to change everything on you. If you are a Muslim, you can wear your hijab, or if you are not a Muslim, you can just dress like you used to dress. However, we need to raise community awareness regarding this. I mean, all of us is having a equal opportunity to create a safe environment. So it's not our only task. We just need to be ourselves. But it's more likely about our society, our community providing a safe environment for us. So maybe there is a regulation by the government that to having a CCTV around everywhere, maybe, so we can minimize the case itself, or even some of area is too dark to pass at night, yeah, because it's less of a facility. So I think it's not our task to change our appearance, but it's community task, government task to creating a safe environment for us. So maybe that is my answer.
All right. Thank you so much for the answer. But we can answer, one more question.
Sure.
I saw one of the audience raising her hand. Or do you guys have any questions? Oh, I'm sorry. I think I lost the one that want to ask you a question. Maybe we can keep in touch to, to discuss more about this topic later.
Please feel free to contact me anytime. You can touch me on WhatsApp or else. You already set my number, right?
All right. Thank you so much, ma'am. So this is the end of the session. But before we finish the session, we would like to give you a certificate of appreciation, and we want to invite you to take photo session also, together with all of the participations. Is that okay?
Yes. Sir.
All right. So please. So, ma'am, this is the certificate of appreciation, and we want to take photos together with you. For all of the participants, please open up your camera. We will take the shoot in 3, 2, 1. All right. Thank you so much. All right, Mrs. Elit Pabriati, Master of Midwifery, Doctor of Philosophy. Thank you very much for joining with us. Really, Podcast Tasikmalaya and me as the moderator, very much appreciated. And also for the audience, thank you very much for being a wonderful participation during this session. Hopefully to see you again real soon. Thank you very much. And for the next session, the presentation will be led by my partner, Delia Maulida. So for Delia, the stage is yours. Udah ada ya? Ya. Thank you to my moderator partner, Ila Rahmawati. Sorry, Jane, for allowing me to continue this seminar session. Good morning. Please, to everyone, allow me to introduce myself. I am Delia Molida Nabila. It gives me a great pleasure to be a moderator of the fourth guest speaker this time. Wow, it looks like we can't wait to get to know and meet this fourth speaker, isn't it? Therefore, may I introduce to you our fourth guest speaker for this session. She is one of the senior lecturer in I System College, Kuching, Sarawak, Malaysia. Maybe some of you here have already know who she is. Okay, before we start discussing, let me read the curriculum vitae of the fourth speaker. To the IT, could you please help me for share the screen of the curriculum vitae? Okay, thank you. As we can see, her name is Miss Rose Nanju, Master of Nursing. She comes from Serian, Sarawak, Malaysia. The last position she held were in the nursing department at the University of Malaysia, Sarawak from 2007 to 2022, where she was a senior lecturer, nursing department, counselor and student discipline or coordinator for student welfare or affair, and inbound, outbound committee in Faculty of Medicine and Health Sciences, and year 2 coordinator in nursing department. Okay, from 2022, sorry, I haven't finished yet. To the IT, yes, okay, thank you. From 2022 to 2023, in the Malaysian Ministry of Health, she has a state registered midwife, state registered nurse, the clinical nursing supervisor at University Malaysia Sarawak, and University Technology Mara. And from 2023 until now, she has been a lecturer at I System College, Kuching, Sarawak, Malaysia. Okay, next. As you can see here, her educational qualifications were at the College of Nursing, Kuching, Malaysian Health Department. She took General Nursing Certified in 1982, Midwife in 1995, and Counseling Certified in 2009. At the University of Malaysia Sarawak in 2009, she took a postgraduate diploma in teaching and learning. And at the University of South Australia Adelaide in 2002, she took a Bachelor of Nursing. And in 2006, she became a Master of Nursing. And wow, there's so many achievements she has achieved at the University of Malaysia Sarawak. And yeah, next. A lot of, yeah. And the newest this year is the organizing committee of International Midwifery Conference. Wait. Sorry, I haven't finished yet. To the previous slide, please. No. Okay, to the research and publication, please. There's a lot of research and publications that have been done in vain. Well, when she was also at the end on a talk show held by Radio Television Malaysia, which discussed interesting topics. Okay, in the final year projects, she often supervises her students' final year projects, even more than 30 students. She also made many proceedings and abstract publications with many
very interesting topics. She attended many talks, conferences, workshops, and seminars, and was one of them is presenter and facilitator of pre-marriage course at Street Teresa Syrian from 1986 until now. And to the gift and awards, please. And yeah, she makes us amazed by the many gifts and awards she received. And one of them was in 2021, she received a COVID vaccine volunteer certificate from the Malaysian Ministry of Health. Okay, the end of the slide, please. And finally, she involved herself very actively in the activities listed here as a member of the society. Okay. Okay, everyone, I have done for read the curriculum vitae of Miss Rose, and I think Miss Rose have already joined Zoom right now. Excuse me, Miss, are you there? Yeah, sorry, Miss, we can't hear your voice. Hello?
Hello. Hello, can you hear me?
Miss.
Can you hear
Yes,
me?
yes, we can hear you.
Can hear me? Okay.
Okay, Miss, how are you?
I'm fine.
Okay, I'm grateful to hear that. All right, Miss, we will start immediately.
Yeah, all right.
Yeah, but before we start discussing, let me tell the audience how the presentation will go. For the first, Miss Rose will present the material. After that, there will be a question and answer session followed by a conclusion. Okay, Miss.
Thank
It
you.
seems like, yeah, it seems like the audience can't wait to see the material you are about to present. Have you ready for giving the material, Miss?
Yes, yes.
Okay. Without any further ado, now allow me to welcome Miss Rose Nanju, Master of Nursing, to present the material entitled Addressing Gender-Based Violence During a Disaster. Miss, please, the stage is yours.
I think my line is a little bit slow. Yeah.
Yeah.
I'm Rose Nanju from iSystem Kuching, Sarawak, Malaysia. Yeah, I have been in nursing and midwifery for almost 44 years now. Yeah.
Oh, yeah, that's
Yeah,
amazing.
I'm a retired lecturer from University Malaysia Sarawak, and now I'm joining the college iSystem as a
Yeah,
lecturer too. Yeah. So my total service is about 44 years. Yeah,
oh,
now
that's
I'm
very
going to
amazing.
present about looks like the previous speakers have already touched a bit about violence against women. So I will talk about violence against women during a disaster. Next. To reduce. Okay, scope of my presentation is to reflect on the presence of gender-based violence during a disaster or conflicts. Disaster or conflicts mean in a landslide, in a lot of the disaster, natural and man-made disaster in Malaysia, and also like what I see in Indonesia, conflicts, war, and all that. Socially differentiated impacts of disaster and conflicts, sex or gender socially differentiated, needs and interests at different stage of disaster, to reflect on and to explore solution to strengthen the sensitivity of organization during a disaster, means how they do the disaster management. So the introduction to my talk is the World Health Organization in Geneva, 1996, although the reference is quite old, but it still says, defines that violence as the international use of physical force or power, threatened or actual against oneself, what the person himself or herself, to another person or against a group or community, which either result in injury, death, psychological harm, and deprivation. So, exclusively, what is the definition of gender-based violence during a disaster? It says here, any act of violence that result in physical, sexual, or psychological harm or suffering to women and girls, also, of course, the transgenders during any disasters. Even when there is no disasters, these transgenders people, they are very vulnerable to violence. It includes threats, ancaman, coercion, or deprivation of liberty, means deprivation of freedom, either in public or private life, during or long after a disaster, or any threat or harm inflicted on a person because of their gender. Sebab mereka perempuan, sebab mereka ini transgenders. So that is United Nations 1993. I quote from them. So again, who split violence into categories like number one is self-directed violence, means that suicidal behaviors. Suicidal ideation. Suicidal behavior, suicidal ideation, attempted suicide, and actual suicide. Number two is interpersonal violence to family and intimate partners. Example, child abuse, violence by unintimate partners, and abuse of the elderly. Collective violence includes war and armed conflicts within or between states, example, genocide and terrorism. Community violence is youth violence, rape or sexual assault by strangers, and violence in the institutional setting. So before we go further into the talk, I have a few questions to ponder here. Number one is, how far are people, including the marginalized, likely to have access to early warning system and preparedness for disaster? I mean, are we given early warning systems? Are we given the warning to be prepared for disasters? And those people, the perpetrators of violence, who are they? Who are these people who cause the violence to the marginalized people? What is the likely impact of disaster on women, men, and transgenders in a disaster? What is the likely access for these marginalized concern to respond and recovery in a disaster? How are they being prepared in the event of any disasters? Are we or are these people prepared during a disaster event? What are their involvement and preparedness and participation? Means that, are they involved in disaster management, or are they only selected people who are involved in disaster management? Like women, are we women involved in managing disasters? If not, where are women? Because the victims of disasters involve women and transgenders. And is there any people who are there as chaperone, whereby when women and children are involved, are they all being taken care by men? And we women allowed men to do it alone to our women. It is there. This violence against women, especially sexual perpetrators, to take place. So what are the factors that leads to violence against women during this disaster? Number one, the weakening of community and institutional protection mechanism. It means here, in any disaster, is there any community? No, like in tsunami, are there community anymore? People are washed away to the pulau-pulau, to the island alone, maybe one man, one woman. Yeah. So those are the things that the dangers, because when, like in tsunami, I just make an example, a tsunami, because all of us were affected by tsunami. So if these women are alone in an island with a few men, what do you think is happening to this woman? Disruption of service? Is there any telephone? Is there any bus transportation service? No, we cannot move anywhere. Community life, as I said earlier, is there any community at that time? There is no community. You are all alone by yourself, at the mercy of all the people. Yeah, at the mercy of the people who are there with you. And if the disaster management people are men, they are the one who will take care of the women. And what do you think will happen? There will be separation of families, alone, displaced. There is no home. You simply don't know what to do. You are displaced. Displaced means you are not in your own home. Then only the people who manage the disaster, and all of them are men, mostly men. And what do you think will happen? I just want to bring you into this situation of tsunami, tanah runtuh. Yeah? Who are there? They are mostly men. And women are at the mercy of these men. And we don't know what type of men they are. There will be stress. The men, the people who are the victim of disasters, they have loss of income. And isolation can exacerbate the risk of violence against women or marginalized men. Marginalized mean mostly the transgenders. Yeah. Orang tua-tua, limited access to justice. In an emergency, in a disaster, there is no justice. Simply nobody there to help. There will be very poor health service, because if the health center is affected by the disaster, nobody is on duty. Only the makeshift hospital, and it is not complete. Disasters such as tsunami, hurricanes, earthquakes, and flood, war, landslide, and the recent COVID-19 pandemic, the MCO, affect women and girls. I have done a bit of research with my student about the COVID-19 pandemic during the MCO. The woman, who is the perpetrators here? During MCO, men, women, and the family stay at home, yeah, cannot go out, and the perpetrators are their own male partner, yeah, the loved ones. They are the one who do all this, the perpetrators of violence, in their very own home. When? How does violence happen? How did it first happen? During an emergency evacuation. Yeah. during flood, for example, they move people from one place to another. Sometimes it takes hours to move. And during that evacuation process, do we know, can we picture what happened? If one or two women and many men, and that this opportunity of violence happen in that way, on the way to the place where they are going to be evacuated. This displacement and return from a displacement place, yeah, to the place if they still have home, and that is where violence can happen. Here, violence by men to a woman is, of course, sexual harassment, rape, yeah. So these women and transgender and the marginalized, they feel very hopeless, helpless. Then they are susceptible to, number one, risk of sexual and physical violence, force or coerce into sex. Tidak cukup dengan itu, they kena jual menjadi prostitute. And ini berlaku. It happened. The children, underage girl, they're forced into marriage just to make sex with them halal. So they force this underage girl into marriage. Human trafficking for sexual exploitation, all these things happen. And sometimes underage girls, they are forced into domestic labor against their will. So, violence against women is an endemic global problem with over 1/3 of women and transgender experience violence against women globally. That is WHO ETAL 2013. So, universal cross-cultural risk factors for violence against women perpetration means that the perpetrators of this violence are why and how and who. They are patriarchal privileges, meaning male supremacy, lelaki, yeah, political leaders, moral authorities, social privileges, all these male, they have all these privileges and control of property. So how did it begin to be so? Why are these men? Where do these men gain the male supremacy, the patriarchal privileges? Any mothers outside there? Can we answer? I'm a mother myself. How do we treat our children the way we brought up our children, boys and girls, in a different ways? What do you want your girls to do at home? And what do you want your boys to do at home? And this affects the way men and women in their later years. Like for the boys, there will be male supremacy. They feel so great. Yeah, they have power against women. So poverty. So when these men, if they are not powerful enough, if they are poor, poverty causes aggression because they don't have what they have, and they tend to be very aggressive. Sometimes the childhood experience of violence and neglect of the perpetrators. Maybe in the early age, they experience violence and neglect at home. So now is the paying time. Balasan. Yeah? So gender issue in disaster situation. Gender disaster preparedness measures often do not reach women, the marginalized men, transgender people. Therefore, Disaster have worse impacts on them. Number one is unpreparedness. They become panic. Once disaster comes, then they succumb to unwanted outcomes. Those underprivileged groups have lesser access to response and recovery measures. They often suffer greater assault on their bodily integrity. Something wrong with my chest. It's right. You hold on, my slide refused to move.
Is there problem with the slide, Miss?
Yeah, I have. Okay, that's okay now. So another one, gender issue in disaster. These groups are less represented in leadership. Women, transgender, and marginalized men, they are less represented in leadership position, even in disaster management. People always think that female cannot do. Female are excluded from all these things, from managing disaster. Their needs and interests are often taken for granted in preparedness, response, and recovery planning. They are not part of the disaster planning. So they do not know what is going to happen, what is happening. This group are given greater family domestic workload. Maksudnya, they say tempat wanita adalah di dapur. Is it true? I don't think so. So, what are the factors that lead to gender-based violence? Again, individual identity. Who are you? Siapa kamu? I am just a woman. You are just a woman. No? Household identity. Keluarga kamu dari mana? How strong is your family? Community identity. Kamu dari kampung mana? That kampung is very poor. Tidak berdaya. Habitat. Dari mana datangnya kamu? You know, this is how people classify people. Pre-existing norms. In certain place, certain community, certain culture, women are always sidelined. They are sometimes gender blind. Gender blind and gender bias is different. Gender blind means kadang-kadang they don't care. You are woman, you are man. What the men do, the woman can do. They
Sorry,
bagi
Miss.
sama rata.
I'll interrupt for a moment. I want to tell you now that you have 10 minutes left. Thank you.
All right, 10 minutes, okay.
Yeah.
Gender bias is where male and female are taken for granted. I mean, they are taken for different. They are treated differently. Kalau kerja, male, they are given higher pay. Female or woman, they are given lower pay. So those are the form of unequal access, exclusion, like I said just now. If people divide something in the community, they only count the male head. The women are not counted. They are denied of their share. Unwanted inclusion, they are not being given the chance. So anyway, a word of caution. Though women and girls bear a disproportionate burden of disaster, men and boys are also affected in gender-specific way. So, gender risk reduction, response and recovery. All these things like food and sanitation need, child and health care, shelter, education, livelihood, violence, participation. Most of the time, female are being excluded. Means that female are not counted. Even in the kampong-kampong, they count the male head only. What about the women, the single mothers? Then gender issue before disaster. More men than women are recruited in disaster management team or exclusion of women. Yeah. Other gender issue during conflict and disaster are men and women involved in different ways in a disaster. Even if women are involved, there will be high rate of sexual violence, increase in number of women-headed household, less involvement in disaster management, huge displacement causes gender issue in response to stages of disaster maksudnya during evacuation, at the evacuation place, and after the disaster. But I'm not going to talk about after disaster, post-disaster, because it's going to be taken by another speaker. So absence of increase in violence, luang dan peruang, such as absence of policy. Mungkin ada polisi, ya, tetapi tidak dipatuhi. Health and support service ada, but dysfunction. They are not functioning. Breakdown of family structures and social isolation, a worsening of existing drivers such as gender and social inequalities, lack of female representation and inclusion in disaster. So, what happened to these victims? Number one, unintended pregnancies. So when they get pregnant, they don't want the pregnancies, and they do unsafe abortions, miscarriage, sexually transmitted disease or infection, poor overall health for mothers and babies. If they continue with their pregnancies, they are already marginalized. There will be poor health for mothers and babies. There will be physical injuries. And not only that, mental health issue, maybe death from murder or suicide. Being so marginalized, they often kill or kill themselves. Solution. As population increasingly affected by climate-related disaster, violence against women transgender can be severe, lasting health impact. So, existing knowledge must inform rapid action across policy and practice. At a policy level, great awareness on disaster-related violence against women and girls, gender sensitive, there must be disaster relief policies. Women must be included in disaster management. It is very critical, at least to chaperone. There must be pemantauan. There must be law enforcement. So gender issue in post-conflict disaster, I will not present that. So my summary is, despite the window of opportunity created by disaster to change societal structures, literature suggests that people, traditional roles are re-emphasized. Gender inequality often worsen after an emergency. Why after emergency? I hope they will be addressed by the next speaker. Studies document that the harmful impact of disaster on social relation across every context. It is the combination of disaster impact and failure of the protective system that aggravated gender inequality, such as violence against women, transgender, and girls. Data on gender-based violence is underreported. Some people, they are simply ashamed to report. So it is always underreported. Although research shows that violence increases after disaster in the evacuation place and on the way to the evacuation place. Pre-enforced disaster vulnerability and capacity assessment should be considered the dimension of violence. Not just sexual and physical violence, but verbal and emotional abuse, intimate partner violence, human trafficking, child marriage for emergency response to really support those most affected. Disaster-induced displacement and forced migration, that is human trafficking, are likely to impact those left behind in terms of their roles, network support and opportunities. Also, don't forget about online harassment after the disaster. So this is my excerpt from COVID disaster. Most of it, I'm not going to read all. Number one is home is not a safe place for me. What can I do? That is during the MCO. I need medical attention because of violence. Who can help me? And where should I go? I'm safe, but I'm suffering from mental, sexual, social, long-term physical health problem because of violence. Is there anyone who can help me during COVID-19? I want to report an incident of violence during COVID. What should I do? So these are the excerpts from one of my research from the victims. That's all. Thank you.
Okay, Miss, have you finished?
Yeah, I have done. I have to hurry
Okay.
because you say I have 10 minutes left.
Yeah, yes. Thank you very much, Miss Rose, for giving such an informative and comprehensive presentation. All right, now we'll move to question and answer session. If you want to ask everyone, you may use the raise your hands feature and write the question down in our chat room, but don't forget to tell your name, okay? Okay, let's
I will
see.
try my best to answer. You just ask question. Or if someone on the floor or the previous speaker can help me to answer, we can share to answer. Thank you.
Okay, okay, Miss. Dari siapa? Okay, wait. 7 messages. It's from Dede City, right?
I can see in the chat room,
Yeah,
there is
actually.
a question there. Ma'am, I want to ask, based on what you have said, the occurrence of violence against women during disaster, if we look at it from gender theory, is it related to assigning different roles and responsibility to men? What does it mean here? What are you trying to ask? And the second question, people nowadays are getting crazier. Prostitution is getting higher and higher, and so many of them get the violence from their clients. The question is, do they have the same protection against women violence regarding the fact that that is her own choice to be a sex worker? I'm not sure of her own choice to be a sex worker. There must be something that leads her into that trade. Don't you think so? Do women, modest women, want to be a prostitute on her own accord? What leads her into that trade? What caused her into there? Remember my last talk? You said that human trafficking, they get this woman to become prostitute. They are lured into in a disaster. I mean, I'm talking about disaster. When they found this woman all alone di dalam satu pulau, what do you think happened? They go on to save the woman. In the end, human trafficking terjadi lah. And then, what happened after that? Many things happen. and beyond her will, beyond her wants, they will be led into this trade, prostitution. And about rape and rogol, rape, yeah. Do you think a woman is responsible for the rape? Is it because the way we dress? Is it because the way we behave? Do you blame women because of the rape? Is the woman all to be blamed? I don't think so. It is all on the mind of the perpetrators, whoever they are, men or women. It is not because of the woman's behavior. It is not because of how the woman dress. It is not because of the woman who wants it. I don't believe that. We have to redesign the brain, the mind of the perpetrators. Woman, if you are being raped, if you're being harassed, don't blame yourself. Nobody wants to be blamed, to be raped. Rape is violence. The mistake is the perpetrators. It is not because the way you dress. It is not because the way you behave. This is my suggestion to women who have been harassed, sexually harassed, or raped. Don't blame yourself. Okay? Any more questions?
Miss, what about the first question
Which one? First question?
from Dede City?
Dede City. Okay, you look
Yes.
from gender theory. Is it related to assigning different roles and responsibilities to men? I don't really understand it. What does he mean by different roles to men? Is it men are given all the roles in disaster? Then they are given all the powers. They feel too powerful. They are very, very powerful. And they can behave sesuka hati. You know, they help, they behave, I mean, the world is mine. I want to show my power. I'm given this responsibility. I'm given this power. The power is in my hand. Is the power given to them to behave violently to women or to the people they save in disaster? It's just like what Malaysians say, seperti pagar makan padi. You know that peribahasa? Seperti pagar makan padi. Because they are there to protect, to save these women, to save the vulnerable people. And yet they are the one who act violence to them. So in Malaysia, we call that pagar makan padi. Pagar tidak boleh makan padi kalau ada penjaga. Means that if there are women around in the disaster management, can the men behave violence against another woman? If I am given a task, I will stop that man from behaving sexually against women, vulnerable women. Is it answering your question, Dede? Is the question answered, Miss Dede?
Okay, Miss Dede, you can answer to our chat room. Is your question answered by Miss Rose?
Yeah, is there any question? No, okay, thank
Okay,
you.
Miss, the time has limit, so we just can take 2 questions now.
Yeah.
Okay. So the presentation of Miss Rose finished.
Thank you. I hope
Yeah.
your questions are answered. You can still contact
Okay,
me
I will
if you
read the
have
conclusion.
anything to do with violence against women. I still can give some more. Yeah. But yeah, my time is only 40 minutes.
Yeah.
And I would like to
Wait,
have a
Miss.
presentation face to face.
Yeah. Okay, wait, Miss. I will read the conclusion.
Yeah.
Okay. The existence of gender-based violence during a disaster or conflict causes a lot of physical and psychological or sexual suffering caused by one's gender. Apart from that, there are several causal factors such as family separation and relocation, financial income problems, limited access to justice, and poor health services. The impact of disasters and conflicts are socially different. For example, the impact of women's health is increasingly severe and long-lasting. Women may be heads of households, or they may not be in their own homes. Even now, there is a lot of marginalization that occurs in women, which is exploitative.
Are you asking me the question or summarizing my you summarize, is it? Yeah. Nothing wrong.
To strengthen sensitivity during disasters, we must believe in our minds that also women, yeah, we can do anything without limits for women, and reduce the assumption, as Ms. Rose says, that the woman not only can be in the kitchen. Yeah.
Yeah. And that's why this
Okay.
violence against women could be reduced if fellow women are involved in disaster management. If we cannot do heavy work, we cannot carry anything, but at least we are there to chaperone the men in the process of doing what they are doing. It's
Okay,
not
it's
that
the
we don't
same
trust the
position.
men, but being men, they are men, so they must be chaperoned. Like in the hospital, in the world, if it is a male doctor, there will be a female chaperone if they examine a female patient. Same in disaster. So that's why we have to recruit more women where the disaster happen in a female area. There must be a chaperone. There must be more
Okay.
female involvement.
Yeah, that's very amazing. That's right, Miss. I agree with you. Okay, Miss, I would like to say thank you to you as a speaker for the great seminar and to the audience for their active participation. We got a lot of knowledge from here from your very interesting and beneficial material, Miss Rose. Okay, thank you very much, Miss Rose
Thank
Nanju,
you.
Master
Thank
of
you for the
Nursing.
invitation. Yeah.
Yes, as talking of our appreciation for your time, Miss, for your time and valuable contribution, may I kindly present to you a certificate? Yeah, certificate of appreciation.
Thank you.
To the IT, okay, here's your certificate, Miss.
Thank you so much.
Yeah, you're welcome. Okay, before we end this session, Miss, maybe could we take some pictures together, okay?
Yeah.
Okay. To the IT team, please help me do the screenshot picture of every slide, right? Okay. We can count 1, 2, 3. Okay, I've done. All right. It's such a grateful and excellent time for us for having discussion with you, Miss. Once again, thank you very much and see you again on another opportunity. Okay. Okay, everyone, the fourth discussion session has finished. We will go straight to the fifth session where there will also be our fifth guest speaker. Just like before, here we are also very curious and looking forward to the material what will be presented by our fifth guest speaker. Just let me immediately introduce the speaker this time. She is one of the lecturers from Tasikmalaya Ministry of Health Polytechnic. Maybe most of you already know who she is. But before we continue with the discussion session, let me first read the curriculum vitae of the guest speaker. To the IT, could you please help me for share the screen of the curriculum vitae? Okay, everyone, as we can see in her CV or curriculum vitae, her name is Miss Wiwin Mintarsi, Bachelor of Applied Science, Master of Health. She is one of the researcher and also the lecturer in Midwifery Department, Poltekkes Kemenkes Tasikmalaya, Indonesia. She pursued her master degree in public health at Gajah Mada University and graduated from midwife professional educational at Poltekkes Kemenkes Tasikmalaya. She is currently a member of Indonesian Midwives Association, or in Bahasa we say IB or IBI, and has been an administrator at the IBI Tasikmalaya City branch since 2015. Yeah. She is a member of training facilitator of Primary Clinical Training Center for Reproductive Health and the Healthy Cities Forum manager in Tasikmalaya City. She is also one of the writers and questions reviewers at APKIN, Indonesian Midwifery Education Association. Her greatest achievements, as we can see here, was in 1996, namely exemplary village midwife at Garut District Health Service. And what amazes us is Miss Wiwin Mintarsi has more than 18 publications since 2015. And her latest publication is Study of Disaster Management Policies on Women and Children in Tasikmalaya. Okay, everyone, I have done for read the curriculum vitae of Miss Wiwin, and I think she have already joined Zoom with us right now. Excuse me, Miss, are you there?
Yes, I'm here.
Okay, great. How are you, Miss?
I'm great.
Okay, I'm grateful to hear that. All right, Miss, we will start immediately. So, Miss, before we start discussing, let me tell the audience first how the presentation will go. For the first, Miss Wiwin will present the material. After that, there will be a question and answer session followed by a conclusion. Okay, Miss, it seems like the audience are very curious to see the material that you are about to present. Have you ready for giving the material, Miss?
Yes, I'm ready.
Okay, all right. Without any further ado, now allow me to welcome Miss Wiwin Mintarsi, Bachelor of Applied Science, Master of Health, to present the material with the title The Role of Women in Post-Disaster Family Resilience. Miss, please, the stage is yours.
Thank you for moderators. Good morning, everyone.
Good morning,
I am
Miss.
delighted to be here who have invitation speaker as international seminary. I also proud for Midwifery Student Association with this activity. Okay, today I would like to take this opportunity to share to you some information about the role of women in the post-disaster family resilient. But I could imagine with a short time I should to give some information about the how to women when he support the family to resilient in post-disaster. My talk divided with some slides related to topics, and I would like to just to give you information about information at the earlier slide, and then I would to explain about how to women as a role in the family for resilient post-disaster. Okay, I would like to share some screen or to share some slide to you. Okay, are you seeing it? Okay. Before I just explain about the slide, are you seeing my slides in the screen?
Yes, Miss, it's very clear.
Okay. Here is the topic as asked from the committee. The topic is the role of women in post-disaster family resilience. And the slide, the first slide, I will be show about the background about disasters. As we know, Indonesia is a country that is vulnerable to disaster. It means we know that disaster problem is caused by various things. It's ranging from the geographical condition and human activities themselves. Disaster is have impact, can augment unequal household gender dynamic and contribute to increase women and children violence. As the speaker before, that the disaster has impact to many activities, even from women and children. Some literature that discuss gender and disasters mention from economic problem, as the ethnicity and has left women and children in more vulnerable, which means women and children has vulnerable to how to survive in a post-disaster situation. Disaster has a direct impact all out of aspect of people lives and often have a double influence for women. It's been women as a subject of victim and beside the responsibility that women should be take responsibility for her families. Here we go to the next slide. I would like to remembering about the disaster management cycle. There are pre-disaster, disaster, and post-disaster level. It means there are 3 parts for disaster management cycle. But in prevention, preparedness, crisis, and response, it will be past. Then disaster has come. But here in post-disaster, women will be held responsibility as a role that I said before, that women have a double burden to hold responsibility when they are activity in her family. In recovery, there are too many activities to restore activities and services. As a speaker before said from Indonesian Health Ministry, Dr. Nida, that in recovery, too many activities that related with reproductive health will be held as a midwife. Yeah. What did you think with this illustration? Could you imagine what happened, what the case will be happen at the situation? Could you imagine? Yeah, you can answer myself. Yeah. Men and women, children and elderly live in one refuge camp. We can imagine it. One refuge camp, all activities they do in one camp, or eat, some activities, or sleep, or many activities like husband and wife can be skipped at that situation. So what would be happen at that situation? Can we imagine what the impact will be at the place in daily activities? Yeah. Of course, yeah. we know women and girls at a high risk. Once high risk, we can underline with the high risk. What is the called the high risk? Yeah, was like Miss Rose said before, women and children, even girls, has vulnerable from against violence. It means harassment or sexual harassment or rape. It will be happen whenever when we have in facing post disaster. Even they live in one camp reviews. That's why how to manage the refuge in the post disaster. Then we will take hold as a midwifery, as a midwife, how to create a safe place for women and children, even girls. How about this? How about this? We can illustration. The camp have more humans. It means there are partition of chamber, maybe men, women, and children. They are live in separate and a part of a place in the camp of reviews. Yeah. Okay, in the and that slide, I'm capturing a picture about reproductive health issue as topic present from Miss Nida from Indonesian Health Ministry. All out, we are as a midwife has a role to provide post disasters. Here we go, how to take responsibility to save the mother or women and children in health issue in a crisis situation. How to provide post-disaster service and enhance the resilience of women and children so as to avoid morbidity and death of mother and children. It means we as a midwife take health of responsibility for health service, women and children. Why did it should do that? Because we know that women have a dual role in carrying out daily obligation in after disaster. Yeah, it mean I will check in bahasa. Seorang perempuan memiliki dua tanggung jawab gitu ya. Jadi dua tanggung jawab yang dimana bahwa tanggung jawab itu adalah tanggung jawab untuk dirinya sendiri dan tanggung jawab untuk keluarganya, bagaimana keluarganya bisa survive. Terutama dalam hal ini adalah kaitan dengan bagaimana pentingnya atau kesehatan reproduksi ini yang bisa terjadi pada saat situasi krisis atau pada saat tanggap darurat, bahkan pada saat post disaster. Here we go to next slide, cause of the problem post disaster. Based from some research, we found that it was explained the ecological damage was also triggered due to climate change or disaster. It has given rise to serious impact on daily life women and also children. It even causes the death of women and children. It means women and children has a vulnerability even from a man. Artinya perempuan dan anak memiliki kerentanan yang lebih dibanding dengan laki-laki. Gitu ya. Experiences that occurring during disaster shows that women and children often become victims, even due to death in the post-disasters. Due to their inability to save themselves, not receiving or being late in receiving warnings. It means before disaster has come, women is rare to have educational about how to preparedness facing the disaster. They are going to, for example, how to moving at the place, how to moving in the security place. Yeah. Maybe the problem of disaster caused by some things, there are burden differences from women and men. It means there are has gender inequality. Men was strong, even women. It means women seen more weak separated with the men. Culture norms. Women tend to depend on the natural environment as a source of livelihood. As I said before, women has to take responsibility as a double burden. Because of that, women is so vulnerability, even the men in family. Okay, here we go in the next slide. Effect of disaster on women. The increased vulnerability of women to primarily due to biological reason is also associated with factors which are socially and culturally. Yeah, the increased vulnerable women, it means maybe the inadequate when relief didn't for it, they have been battered for food. In the last post-disaster period, girls may be married of a much younger of with all the other person in situation crisis. Here in the figure, I show various socio-cultural consequences are graphically present. Which means disaster has effect by three parts: physical impact, emotional impact, and socio-economic impact. From the physical impact, shortness, sleep disturbance, eating disturbance, gynecological problem, injuries, miscarriages, and another thing, till they have rape. It means women and children is risky from rape against or sexual harassment. That's why before this presentation, Ms. Elite said there are several things we must be done if sexual harassment or rape that happen, but in disaster situation, it's not easy to report about how to situation. This is relatively with a difficulty to express how to women and girl expression that are have against from men in camp reviews. In the second level, that emotional impact maybe causes by anxiety, effect, anxiety, fear, humiliation, dreams, and nightmare. It means every people, even men, women, and children cannot sleep, cannot make a deep sleep because anxiety, because the fear, maybe disaster will become again. They are have a humiliation dream, mimpi buruk dengan adanya disaster atau dengan adanya bencana tersebut, sehingga sulit gitu ya untuk bisa mendapatkan sesuatu dan akhirnya itu menjadi trauma gitu ya, menjadi apa namanya ketakutan ya, jadi sangat riskan, sangat irritable, artinya sensitif terhadap situasi, sedikit-sedikit marah ya, to be anger. And then the latest is socio-economic impact dealing with the new societal roles like being a widow, single parent, or head of house. We can take in bahasa. Kita bisa membayangkan terkait dengan socio-economic impact atau dampak terhadap sosial ekonomi, bahwa ketika terjadi bencana itu ya pasti ya akan berdampak terhadap kondisi ya. Too many women become a widow, single parent, how to take a responsibility to her family life without lands, without some money, without atau no activity, it just depend to other one from the help. Jadi kalau sudah dalam situasi bencana, banyak pasangan yang memang kehilangan pasangannya, terutama perempuan bisa menjadi janda gitu ya, kemudian menjadi single parent yang harus membesarkan anak tanpa bisa mendapatkan hak rumahnya itu bagaimana, atau di mana mereka harus tinggal, ataupun bagaimana dengan keuangan yang mereka bisa dapatkan seperti itu. Ya. The next slide. we will discuss about women in critical situation. Women are catalysts for change for communities, families, and the people around them in critical situation. As I said before, women has many responsibility for her family. They are take responsibility for her own soul, or take responsibility for the children, how to give eat, how to lead day to education, or another thing, then make in around critical situation. And then women are present as actors who play an important role in critical situation and have coping mechanism and capacities that are different from men. That's why the reason how to make empowering women to face critical situation because of this state. In critical situation, women who have coping mechanism have capacities that are different from men. It means if men just take responsibility how to seek about something, maybe some food, water, or another thing, but the women have responsibility how to take care of children, even if women will be pregnant in labor from the labor at the critical situation, or postpartum with a baby, how to give breast milk to the baby in the critical situation. The present or patriarchal ideology in society conversation and values that portray women and subordinate and always depend on men. Here we can underline subordinate. It means that are occur about the marginalization women and children. Even depend on men, and that's why basically the values of patriarchal culture are the roots of the oppression that has been happening to women. And the last step, women in critical situation see being as an agent of change in family. There are as the topic how to the role of women in post-disaster family resilience, because the women take responsibility as an agent of change. Jadi bagaimana seorang perempuan ya bisa menguatkan atau bisa menjadi agen perubahan pada keluarganya. Artinya dia tadi menjalankan berbagai tanggung jawab terhadap keluarganya ya. Jadi dia bertanggung jawab terhadap dirinya, bagaimana dia tidak boleh sakit, bagaimana dia tidak boleh menyerah atau tidak boleh sensitif, dan harus bisa memperjuangkan bagaimana mempertahankan keluarga ketika situasi pasca bencana seperti itu. Ya. Okay, if the attendant have any question, you can raise hand in your device or write in the chat box.
Okay, Miss, have you finished the presentation?
Maybe a few slides more. I will be held to discipline. Okay.
Okay.
Just permit for a minute. This is a role of women. The role of women in the post-disaster period includes role in service reproductive health, access to educational and skill, as well women participation in rehabilitation and reconstruction effort. Here I'll write about the 3 levels from mitigation, crisis, and recovery and reconstruction when a disaster occurs. Mitigation, we take hold providing information. It means as a midwife, we should give some information how to take preparedness if we're facing disasters, socialization, and training and simulation. It's more important prepare from disaster happen, from disaster crisis, because we have a long time for preparedness about the disaster. That's why providing information, socialization, and training and simulation in take place before a disaster how we come. And the crisis, it's of course emergency response as role. We as a midwife, it means as a health service is a part of component who take responsibility for emergency response or tanggap darurat in bahasa. Jadi kalau kita sebagai bidan itu merupakan bagian daripada pelayanan kesehatan atau yang memberikan pelayanan kesehatan yang menjadi bagian dari semua unsur ya, seperti tadi yang disampaikan bahwa ada klaster-klaster yang memang harus menjadi tanggung jawab kita. And then the latest is recovery of reconstruction. Here we have a responsibility that the role of women. How to women will be take responsibility as part and prevent family resilient post disasters. There are several factors that influence post disaster women resilience. We know there are burden differences between men and women. I talked it many more before. When facing the impact of change in the post-disaster situation, so they will become of the causes of the problem. For example, women are weaker as the parties who feel the influence of the change the most compared to men. But women who have self-efficacy, coping skill, and a sense of belonging which contribute to the formation of women resilient had strong survival. It means from the earlier in mitigation disaster, women will be to ready with preparedness how to facing the disaster. Because the state women who had self-efficacy, it means jika ada seorang perempuan yang memiliki kepercayaan diri, kemudian bagaimana dia bisa mempertahankan diri dengan kuat, maka dia juga akan bertahan lebih lama dibandingkan dengan yang lainnya. Jadi seperti itu. In addition, spiritual factor and strong optimism that arise from individual also influence the increase in resilience. Don't be forget the woman has a role as agent of change. Because of the reason we are as a woman should be strong to facing all the case or the activities when we facing the disaster and protect the resilient for family. As a conclusion, investing to increase women resilience for family and preparedness facing disaster is important. And the second, it needs to have planned women empowerment by educational training and simulation. And the latest, participating of women in decision making are important. So that brings me to end my presentation. Thank you for your attention. Also, it was a pleasure being here today. Thank you for all. Hello. I have done with my presentation.
Yes, Miss. Okay. It was a great presentation, an informative and comprehensive presentation. Wait a minute. All right, Miss, now we'll move to the question and answer session.
Yeah.
Yeah, if the audience wants to ask, okay, there is a question from the room chat. Okay. Okay. For the first question, here is from WOC. Yeah. Okay, the question is, namely, what kind of double influence has a direct impact on women? And secondly, is there any further attention and action from the responsible for maternal and child health to improve maternal and child health after disaster occurs, and what form of attention does this take? Miss, do you want me to?
Okay.
Okay.
I will be try to answer the question. Yeah.
Okay.
What is the mother and children to take help in post-disaster? As I said before, in illustration from the Indonesian Health Ministry that have PPAM, yeah, the PAM, yeah. We as a midwife take health responsibility to give a service. Was like is cluster by cluster. That's why we should to ready with PPAM and take it educational to the people, even the women and children. So we can fix with how to roll the midwife when we it's been terlibat di dalam penanganan bencana tuh ya. Jadi we as a midwife as a part of component as a subcluster in health reproductive for mother and children in situation in a crisis situation. It's not more because that are role how to give a service from each component. Hello?
Okay, Miss, have you finished answer the
Yeah.
question?
Yeah, maybe my answer just has explained about that question.
Okay. To Miss Ossie, is the question have been answered? You can answer in the chat room. Okay, maybe already right. Okay, Miss, there is the second question from Nabila Takiyah. Okay, thank you. What is our role as students in empowering women after a disaster?
Okay, thank you for the question. As we know, the student is part of the people who held responsibility as a volunteer when take responsibility when we have to how to serve how to give a health service in crisis situation. But the student will have obligation as a student. They are take responsibility by program study to teach student how to prepare, how to make a readiness by self as a curriculum to access, to achieve and ready. Prepare when they involve as health resources pioneer at post disaster management. Jadi dalam bahasa Indonesia saya bisa menjelaskan bahwa bagaimana peran seorang mahasiswa dan tentunya bahwa peran mahasiswa itu tidak terlepas dari apa yang menjadi kewajibannya sebagai mahasiswa yang nanti diajarkan oleh sesuai dengan kurikulum yang ada di program studi begitu. Dan semua tentunya bahwa was like Midwifery Department in Health Polytechnic Tasikmalaya, we has a curriculum about the women empowering in community. So we can finalize with step by step how to student will be ranking in preparedness by self if they will be taken responsibility as health resources in post-disaster crisis management. Maybe this my answer for you, Nabila.
Okay, to Nabila, is the question answered by Miss Wiwin? Okay. Okay, maybe she already know the answer. Okay. All right, this question and answer session has finished. Thank you for your amazing explanation, Miss Wiwin. All of the question has been answered. Yeah, for the limit times, we just take 2 questions. Okay, before we end this session, allow me to read the conclusion about the discussion today. Okay, women can be responsible for themselves and their families to achieve family resilience. Moreover, during post-disaster times, women and children are more vulnerable group than men. Sometimes the cause is that there is gender inequality between women and men. The impact of disaster on women is physical impacts such as sleep and eating disturbance, physical impairments, and emotional impacts such as anxiety, embarrassment denial, anger, or more sensitivity. And in socio-economic impacts such as societal roles like being a widow, single parents, or head of house because they lost their partner without being able to get their money or house. Women in crisis situations play an important role as responsible agents of change in their families. As midwives, we must provide important information, socialization, training, and simulation regarding reproductive health, access of education, and capacity of rehabilitation efforts. Finally, now we have reached the end of this seminar. I would like to say thank you to Ms. Wiwin as a speaker for the great seminar and to the audience for their
Yeah,
active participation.
Yeah,
We got a
thank you
lot of
for
knowledge.
invited.
Yeah, we had a lot of knowledge from you, Ms. Wiwin. Okay, thank you very much. As token of our appreciation for your time and valuable contribution, may I kindly present a certificate of appreciation to you. To IT team, please help me share the certificate through the screen to Ms. Wiwin.
Of
Okay,
course,
here
thank
you
you for the
go.
certificate. I'm
Yes,
so proud with you all as a committee and as a student of the Midwifery program in a
yes.
Polytechnic Kemenkes Tasikmalaya. Thank you
Actually,
for
we're each other. We're proud. Yeah. All right, ma'am, here's your certificate. Yeah. Okay, before we end this session, maybe we could take some pictures together, miss. Okay, everyone, open your camera, please. To the IT team, please help me produce a screenshot for the slide. Okay. I count 1, 2, 3. Okay, you ready? It's such a grateful and excellent time for us for having discussion with you. Once again, thank you very much and see you again on another
welcome.
opportunity, miss.
Yeah. Welcome for all the and I would like to say thank you for all the participants who attend this session and for the whole committee too.
You're welcome, miss. Okay, everyone, may I thank you very much for your active participation and enjoy enthusiastically in this seminar session. I hope these events can provide many benefits for our life. All right, I hand over from this end session to the master of ceremony.
All right. Thank you for all of the moderators who has lead the presentation from our amazing speakers.
For the next agenda, we will announce the best questioner that will get an interesting prize. All right, Hilda, from a lot of questions that has been asked before, in your opinion, who will be the best of the best that will receive the prize?
This is very confusing because all questions are very critical and amazing, right? And also there are a lot of questions that hasn't been answered because our limited time.
All right, but we need to choose only 3 best questions, and this winner is chosen by the enthusiasm in the Q&A session and suitability between the question and topic.
All right, Desi, Let's announce the winner now.
Okay. The first winner, Osi Miriana.
Alright, Desi, let's move on to the second winner. Okay, for the second winner is
Cinta Nuraini. Okay, and the third winner is Nabila Takia. Wow, Hilda, these questions from our audience at this event are truly extraordinary.
You're right, Desi.
Okay, congratulations for all winners. So you can claim the prize by contact the number below.
And the contact person will be sent in the chat box. Hey everyone, and for other participants who haven't received a prize, encourage because there's still many opportunities.
Ladies and gentlemen, the event of international seminar Rising to Resilience for Women and Ending Violence in Disaster 2023 has concluded. Let's close this event by saying Hamdalah. Alhamdulillahirabbil alamin. I am Desi, and
I'm Hilda.
as a master of ceremony and all of the crew ask for leave, we'll apologize for our mistakes and imperfections. Thank you for your attention and cooperation. Wassalamualaikum warahmatullahi wabarakatuh.